Hello, uh, very good morning and welcome you all for the fifth lung cancer masterclass workshop. I'm happy that I've been organizing this workshop for the last 5 years, and I could see the lot of delegates, around 72, I suppose they are supposed to join, and many of them joining from online this. So without wasting much time, I will introduce Dr. Akhil Kapoor, who is the speaker, our first speaker. He'll be discussing on stratification and prognosis of NSCLC using NGS. Dr. Akhil Kapoor is Assistant Professor, Medical Oncologist, Tata Memorial Hospital, Varanasi, and he is a very active member. We miss him on the MTB if ever he's not there. So we learn a lot of things from him. So Dr. Akhil, please come. Yeah, you want to take a pic? Yeah, okay. Hello. Thank you.
Thank you. Thank you, ma'am. And a very good morning to all of you. So definitely, we all know now that NGS is the need of the hour. I will just highlight a few important points, how it makes it different, how it impacts the decision of a clinician, because I'm a clinician and we have worked a lot with ma'am and we have learned lot of things from madam. So we know that uh, lung cancer is a disease. It is a mixture, it is a heterogeneous disease, and around 50% patients have some or other kind of mutations available. Just the thing is that you need to identify them properly. This is the impact of targeted therapy, which are we all are aware. Osimertinib, the data is huge. It can significantly impact the progression-free survivals and even overall survivals. Data with ALK inhibitors. Now we are talking about 5-year survivals very frequently. Initially, we were thinking whether to treat or give best supportive care alone around 15 years back. Now we are talking about 5-year survival. So that is the leap which we have made in the field of science, and that we also always say lung cancer is the poster boy of personalized therapy. Let's continue that. This is the standard algorithm. I will not go into detail of it. We are all clinicians are aware of the same, but the main point is that everyone should be able to do testing so that target can be detected. If you cannot detect the target, you cannot treat with a targeted agent, and targeted agent lead to a significant improvement in the survivals, which we are very well aware of. So there have been multiple studies even in early stage cancers, in adjuvant settings. So biomarker testing is now not limited only to metastatic settings. It has now come up even in early lung cancer, post surgery, now post radiation also it is coming up, and adjuvant treatment. So definitely it is making a lot of difference. We initially thought it is a thing only for the metastatic patients where we can offer only systemic treatment. No, now we know it is required even for patients who are undergoing curative intent therapy. So we need to be aware of all the things. This is the whole big list of mutations which we are very well aware of. Data from TMH is also available. When we see even a patient with EGFR, EGFR sensitizing mutations are also different. We need to understand even single mutation which we have identified on EGFR by a COBAS version 2, there are many connotations to that. I will come to each one of them one by one. We'll see them. This is the problem. Tissue is the issue. Our pathologist senior, Dr. Rajiv sir, always tells that tissue remains the issue. That is why it is very important to have a parallel testing so that we can detect multiple targets at the same time and do not waste the tissue. This is what happens actually in the sequential testing. The tissue gets depleted. That is why we try to use minimal amount of IHC if required, even required. Sometimes IHC is also not required for characterizing adeno versus squamous, but when it is required, it can be done very limited panel so that you save the maximum amount of tissue for molecular testing. So why upfront testing matters? There is a great study available. Patients with driver mutations who received targeted treatment versus who could not receive targeted treatment. You can see the outcomes are very well different. survivals are between 18 months who could receive targeted treatment and had driver mutations, while those who could not receive targeted treatment when mutation was available, it was starkly different. At least half the overall survival becomes half when you are not able to use targeted treatment to treat a mutation. So definitely try to give the best possible treatment upfront. Don't wait for the second line, third line, because what happens, this is the real example, lung cancer, at least 30% patients will not be able to receive next line of treatment. That is why it is from a clinician point of view, I always try to use the best possible treatment. If target is always use targeted treatment, don't think if the patient progresses on chemotherapy, then I will use a targeted treatment, because what happens, at least 30% patient will not be able to receive next line of treatment. Why? Their performance status will become so bad that they will not be able to receive any treatment. So that should be kept at the back of mind while deciding any treatment. Don't think your patient is doing very well on chemotherapy and said later we can use target treatment. So this is a paper which we discussed recently. Anuradha ma'am asked me for the full text of this article. This is EGFR exon 19 deletion subtype, and a detailed analysis from China is now available for the same. It has been found that patients with EGFR E746 to 750 deletion, which is the most common deletion subtype, had a significantly higher frequency of acquired T790 mutations when treated with first or second generation TKI, while other types have somewhat lower frequency. So it helps us to identify what are the chances of having T790M mutations as well. And also there are some specific mutations, for example, 751 to 759, 751 to 756. These are have different prognosis. There's also, these are sometimes missed by a COBAST version 2 test, and sometimes these are not even covered in the 42 mutations which are present in the COBAST. So it is important. Apart from exon 19, exon 14 mutations are also sometimes available. These can be missed by the RT-PCR. That is why it is important to do NGS. That is what I wanted to highlight. One slide more. This is the paper which we discussed in our last molecular tumor board. The beauty of molecular tumor board is that we keep on learning, we keep on enriching each other's self. So that is how the field is evolving, and it is always important to have a good discussion involving both the molecular oncologist, pathologist, oncologists. So that is the way to go. Never anybody can think I know everything, and we should keep learning. And this is what happens in our molecular tumor board. And this is a paper, another paper, which characterized EGFR exon 19 C helix deletion. C helix deletion can be very commonly mixed with the RT-PCR test, and this is 2.5% exon 19 deletion occurs in the C helix part of exon 19. And for example, 751 to 759 deletion has PFS of around 2 months only. While there is clear-cut multiple case reports available, if you identify this mutation, if you treat with afatinib or osimertinib, you have PFS of up to 8 to 10 months. So just identifying the exon 19 is also not enough. You need to see what type of exon 19 it is. So this is the precision clinic, precision medicine, which we need to understand. Just getting that patient exon 19 deleted, this is also not now enough, because around 70% will be in the overall classical variants, classical types, but 30% might be some uncommon ones where we know we need to select differently, even in exon 19. We'll come to exon 20 later on. This is exon 20 that I was just talking about. Yes, exon 20 is also a very wide spectrum where we want to know whether a patient is going to have treatment benefit with TKI or not, whether patient deserves a treatment with amivantamab, which is now available. All multiple trials are available in India. TMH is also a participating center. So we need to understand each of them. And also you can clearly see the patients with exon 20 insertions who are able to receive first line TKI, sufficient TKI, the survivals are much better. So this is what I wanted to highlight again. If we identified exon 20 mutation or deletion or insertion by RT-PCR, that will not help us to decide what treatment has to be taken. If this is an NGS report where we can identify the exact site of insertions, then it becomes very useful. You can clearly see there are some sites which you can see it is sensitive to first line TKI. For example, you can clearly see this is 763 and 764. If you can identify it by NGS, you know it is sensitive to first line TKI as well. if there are some mutations, some insertions, which you can know it is sensitive to poziotinib or drugs like mobocertinib. Also, some sites like 773 and 774 are afatinib sensitive. So, how you can decide to treat when you don't know which type of insertion is there if you don't do NGS? So that is the importance of NGS. Just knowing that there is an exon 20 insertion, it's like just again hit and trial method. You give one drug, patient progresses, then you give next drug, patient again progresses, then you give third drug. Might be patient is not able to receive that third line or second line treatment. So that is the benefit of doing NGS and identifying the exact type of insertions in exon 20, which is not possible by using a RT-PCR. So this was a lot about EGFR. We know MET exon 14 skipping mutations cannot be easily detected by other methods than NGS. Even we know DNA based NGS, RNA based NGS are different. RNA based NGS holds a very important promise in identifying especially the fusions, and they remain the key to identify exon 14 insertion, exon 14 skipping mutations for MET. Similar is the case for other fusions like RET and others. I will be coming to some perspectives for immunotherapy as well. We are actively working on biomarker identification for immunotherapy in lung cancer, and I have applied for ISLC grant for the same as well. Hopefully, if we get some grant, we'll be able to do much more work on this particular area, because we know around 40 to 50% patients have mutations, but rest 50% we are not able to identify mutation despite doing an NGS. And even if we identify mutation, some are not targetable with the present available drugs. So the situation remains, out of every 2 patients, in 1 patient, you have to utilize immunotherapy and other drugs, not only chemotherapy. So PDL1 is always there. It has there from last 5 years, but whether it is able to actually predict, we know it. Even in PDL1 high, patient sometimes responds poorly. Even in PDL1 low, patient responds somewhat well. So that remains a problem. Biomarker identification remains a big problem. So there are some mutations which have been identified which predict the response to immunotherapy as well. STK11 and KEAP1 genomic alterations. There is clear data. If these are present, the survivals drop down. The progression-free survival with immunotherapy is highly dependent on these mutations or genomic alterations if present. There is clear curve separation. If these mutations or alterations are present, it will help us to know, yes, this patient is not going to do well on immunotherapy. So at least prognostic information will be available. Whether you have any other option, I'm not sure, but at least you will know this patient is not going to do well. So this is it is independent of the PDL1 levels as well. So if you identify high tumor mutation burden, high PDL1, but at the same time you are finding STK11 mutation or KEAP1 mutation, be very clear. This PDL1 and TMB is not able to predict the responses if these mutations are present. So it has independent prognostic value apart from PDL1. So PDL1 itself is not enough. We need to identify various other mutations with the help of NGS, even in patients who are candidates of immunotherapy. So this is same thing. I will be coming to now some recent paper. This has been published 7 days back only in the Nature Communications. This is a very good journal, and it is always try to find some newer things which might be actually useful for the clinicians later on. So recurrent somatic mutations as predictors of immunotherapy response, another very good paper and deep insight. So they have found around 6 mutations, recurrent somatic mutations in not only in lung cancer, but also in urinary bladder cancer and melanoma, where they found that BCLF1, that is BCL2 associated transcription factor 1. This is a marker which predicts poor responses to immunotherapy. You can see this curve is towards the lower side. That impacts clearly implies that these patients have poorer responses to immunotherapy. Similarly, TP53, we are very well aware of TP53. In our molecular tumor board also, we see a lot of patients with TP53 mutations, and we are analyzing the TP53 data separately in our molecular tumor boards. And we have now P53 mutations, more than 100 patients where we have identified P53 mutations, and we are looking to analyze them separately. So other mutations, KRAS and BRAF, these have been found to be somewhat favorable response to immunotherapy if these mutations have been identified. Odds ratio of 6 and odds ratio of 2. So this is the odds ratio on the left side. So odds ratio of 6 and odds ratio of 2 with BRAF, this have been identified. So this was the thing. So even with immunotherapy, you need to understand there are multiple somatic mutations which can help you to prognosticate the patient whether they are going to respond or not. So this is again BCLF2, BCLF1 mutation, which identifies even a patient who are having high tumor mutation burden but not going to respond with immunotherapy. So if patient is having a very high tumor mutation burden, still patient is not responding to immunotherapy, you can blame on BCLF1. And if you can identify that previously from the NGS or any other method, you can be understanding that this is patient is not going to do well. So to summarize, there is a clear data available that you need to incorporate NGS for best possible management of your patient. I clearly understand the logistic constraints. I clearly understand the various problems which are associated with doing an NGS, but doing NGS on large scale has led to coming down of the cost. And that remains the key. If you can do a test which is not for only 10 patients, it is for 100 patients of your institute per day, definitely it will change the cost of the test. It will definitely, if you are able to utilize the test in bulk, definitely the cost come down. So it is very important to identify the patients where you are able to do NGS, you are able to incorporate NGS in your routine practice. This is a big problem, and hopefully with support of our molecular team and support from TMH medical oncology team, we are able to surpass that. So choosing wisely remains the key in cancer always. Lung cancer is again a poster boy for the same. So you must choose, but choose wisely. And with that, thanks and greetings from Team HRRC. Thank you.
Thank you, Dr. Akhil, for a very comprehensive talk and highlighting many of the biomarkers which are coming up, like BCLF1, how important it is if you have a good tumor burden. The talk that is open for the discussion. Anybody having any questions can please. Amit.
So patients who have this STK11 KEAP1 mutation, do you still want to give immunotherapy, or is it an absolute marker not to give immunotherapy?
We know that the PFS is around 2 to 3 months with these mutations. But if you don't have any other options available, you can consider, if you have any other option, for example, you are finding a mutation which has, for example, you find a patient who is having KEAP1 mutation, but at the same time, the patient has some other targetable mutation which is known to have PFS of 5 to 6 months. I will then utilize that option, because it helps us. It will help us to know that this patient is not going to do very well on immunotherapy. Also, while counseling as a clinician, we need to tell the patient that what amount of PFS or OS is expected while giving a treatment, because immunotherapy remains very costly treatment. And if I tell a patient that the average PFS and OS is around 10 months, but I know if there is a KEAP1 mutation or STK11, I will prognosticate and counsel accordingly. So as a clinician, it makes me and have a knowledge about the prognosis and counsel the patient accordingly. Because if I counsel the patient to say, you will have a PFS of around 10 months, I hope that you will do well for 10 months, and the patient progresses only on 2 months, it will be like a failure of a clinician. But if this thing is available, I will be able to prognosticate accordingly, and it'll help me in guiding the patients.
Should we add chemotherapy with immunotherapy in this scenario?
There is some data now coming up where the combination of quadruplet, chemotherapy, immunotherapy plus bevacizumab, might be able to overcome some problems which is there with these mutations. For example, even in EGFR and ALK, we know the patients who have progressed on EGFR ALK based TKI, no further TKI is possible. ABCP has some data. So similarly, in these patients, I try to use ABCP if feasible. Thank you.
Questions? I have one question, just a question, like in your clinic, if you want to have NGS or first EGFR, because EGFR is a potential marker. So will you like to have the EGFR report at earliest, or you will wait for the NGS report to come where EGFR is also covered?
So, ma'am, that depends on the turnaround time of NGS in your own institute. If you have in-house NGS and you know that the report is going to come in 2 weeks, it is fine to go ahead with NGS first. Because not doing AGFR is sufficient. But if I see that I have a turnaround time of more than 4 weeks, I would be happy to do at least EGFR and ELK, so that I'm aware that patient does not have a long waiting time before starting treatment. So that completely depends on the turnaround time, the logistics available.
Okay. And since you being at the Varanasi, how you come up challenges for the NGS reports where you are outsourcing?
Yeah,
right now?
ma'am, definitely. That remains a big problem. Sending an NGS to TMH Mumbai takes a significant amount of time. There is transport time involved. A pathologist needs to evaluate again at Mumbai before marking the area for testing the tumor and testing. So that is a big problem. So we are working very hard so that we can start molecular lab, fully functional molecular lab. Till now we have RT-PCR and other tests, but we are working very hard to start NGS at our institute.
Thank you so much. We move on to the next speaker, Dr. Vidya Veldore, who is a clinical director for Forbase Care Onco Solutions Private Limited. Her talk is on why liquid biopsy is important in clinical routine. Vidya.
Good morning. Thanks to the organizers, Kumar sir and Anuradha madam, for this opportunity. And today I will just walk you through why is it important to have liquid biopsy in clinic. In addition to that, we will be sharing our pilot validation study along with some clinical case study experience on usage of liquid biopsy in a CGP approach. So technology is constantly evolving. Medicine is something which we are constantly learning till we are alive on this earth. And I think we are here to adopt this technology as and when it comes, but we need to be careful on what are the pros and cons, what are the limitations of technology, and then take it to the clinic. So on the right side, we have the liquid biopsy or cell-free DNA that is a derivative from liquid biopsy. And what are the sources? Apoptosis, necrosis, and netosis. And you also have sometimes DNA being secreted into the plasma. So we all know liquid biopsy is a complementary approach to tissue-based biomarker testing when we do not have adequate tissue available for molecular profiling of tumors, or when there is a rebiopsy that's not possible and the patient's performance status is not so good. And what is it? It's a minimally invasive procedure, and you can just do it with a peripheral blood of minimum of 6 ml. And the blood can be stored at room temperature for only period of 3 hours if it is EDTA. But if you want to store it for more than 3 hours, we need to move on to a stabilizing solution that is a Streck tube. And it has been validated by this commercial vendor Streck tube that cell-free DNA is stable for more than 72 hours without further degradation, cell-free DNA being a very labile molecule. So here, what are the potential applications of liquid biopsy in clinic? So now there is this, game changing that's happening where one wants to look at both tumor as well as liquid biopsy based baseline approach to understand the complete molecular landscape of the disease. And it also helps you in understanding when the tumor shreds into circulation, what is the quantified burden of tumor in circulation. And of course, it helps in follow-up. And it helps in minimal residual disease estimation. And when the patient is on surveillance, one wants to detect early relapse. There again, liquid biopsy has a potential. And it also helps not only in profiling classical genomic alterations, it also helps in profiling genomic signatures. So we in our laboratory has been able to profile all the way up to whole exome as well as comprehensive genomic profiling on large gene panels, and we have validated in-house with in-house tools. So, so what is the important challenge is tumor heterogeneity. It shows here, as you take the needle through the tumor core, you see that some of the mutant clones, each one represents different mutations. Some of them are sampled during the biopsy, where some of them would be left out. What liquid biopsy has an advantage is it gives you a holistic picture of the disease by having most or all of the clones from not only the local site, but also from the metastatic sites released into circulation. Therefore, you get a complete picture of the disease. So what are its advantages? It is minimally invasive, and it can be repeated to monitor the evolution of the disease and also change the therapy while you monitor the disease. Unlike imaging, which is associated with repeated risk of radiation exposure, it has very minimal or no risk while doing a liquid biopsy sampling. And it also represents the complete tumor heterogeneity, provided the biology of the disease allows it to release in circulation. And I must say, it's a submission. It remains only a complementary tool. It cannot be a first-line tool. Tissue biopsy and histopathological diagnosis remains the gold standard for diagnosis of malignancy. It can only work as a complementary tool to address the molecular signature or the molecular understanding of the tumor. So as recent as yesterday, EMQ and ESMO together had released guidelines on NSCLC biomarker test in specimen management, where they have mentioned a section on liquid biopsy, where the aspects which we discussed earlier had been explicitly stated that we have a role for liquid biopsy when tissue is inadequate to look at molecular drivers. We also have a role for minimal residual disease estimation and response assessment in liquid biopsy. So what are the technical factors that would affect the diagnostic yield of liquid biopsy? How much is the disease volume and its location have an effect on cell-free DNA and ctDNA indirectly, because ctDNA and cell-free DNA is more like a milk and water mixture. It is very, although there are some studies and some publications that talks about cell-free DNA and ctDNA can be segregated, nobody has come up with a robust assay to prove that ctDNA is 100% to the accuracy that yes, the disease corresponds to these many ctDNA molecules. So it is good and wiser to be limiting ourselves to cell-free DNA than going into the ctDNA aspect of cell-free DNA. And in a metastatic setting, particularly when there is a high disease burden, there are studies which have shown that there is an increasing shedding of cell-free DNA, and that indirectly corresponds to higher ctDNA as compared to an early stage disease. So here again, one has to take a call. Is it right to go for a liquid biopsy if the disease is confined? And sample collection, at what time of the journey of the cancer patient we need to collect liquid biopsy? That plays a very, very important role. If there is debulking or surgery already done and most of the tumor has been removed from the body, then the liquid biopsy yield for tumor related alterations would be very, very minimal, or you would be ending up getting false negatives. And so again, last but not the least, tumor biology plays a very important role, whether it is early stage or metastatic setting. Not all tumors release cell-free DNA in the same fashion into circulation, and therefore there is room for a lot of research. And the future is to use the technology of liquid biopsy in different cancer types, but we cannot expect to see a clinical validation that shows 100% concordance at all stages of cancers. to say that liquid biopsy is the tool to go forward. Now, there is inter-individual and inter-study comparison, has a challenge, because we know that at tissue level, now we see the same challenge even at liquid biopsy level, and result interpretation and reproducibility. So the result interpretation and reproducibility particularly has a lot to do with the spatio-temporal variation, as well as the labile nature of cell-free DNA, half-life being less than 2 hours. And how do you overcome this limitation? So this is where technology comes into picture. If you have a good technology that is analytically validated, I want to put this quote in quote, analytically validated. That means the assay is good to go. You have verified with reference materials and standards, as well as analytical samples, and then you implement that into clinical samples, you get to see answers based on the biology of that particular patient's tumor. But you cannot expect to see a tissue versus liquid biopsy 100% concordant at every stage of the disease, as the journey goes for every cancer patient. So our journey through liquid biopsy and tissue biopsy. So this is the target indigene panel, which we used for validating both tissue and liquid together. It is an indigenously developed panel, which is derived from profiling of 1,500 cancer patients across India, with collaboration with multiple academic centers across India. And it is a comprehensive genomic panel that addresses most of all the genomic alterations that today is used in cancer management, like gene fusions or mutations, TMB, MSI, and copy number alterations. So here is a quick snapshot overview. In any CGP, the design becomes very important where it gets applied to the clinic. Unlike in tissue, where you have an opportunity to do both DNA and RNA being used for fusions. In cell-free DNA, the cell-free RNA is something which nobody has been able to reproduce very accurately in a very large scale. Therefore, cell-free DNA is the only source of material, clinical material, that remains with us. Here comes the question: can you design an assay that can work accurately to address the technology, as a basis of biology? So the biology says fusions happens in introns. And therefore, if you can sequence the complete intronic region, you are not missing the fusions. And that is where the design of NGS panel comes into picture. So on the top, we have an RNA-based gene fusion, where you see the green and red exons joined together, and you see the sequences here. On the bottom, you see a DNA-based gene fusion with reads, these reads supporting the intronic region. And if you are able to design a panel where an intronic region can be adequately covered with good number of reads, and if the tumor burden is really good, then your detection of gene fusions or exon 14 skipping alterations or any other alteration that is important in the non-coding region of the genome becomes very accurate. This is just a classical case study from our liquid biopsy, where you look at, there's a patient with primary driver mutation, and you looked at the tissue as well as liquid biopsy baseline for the primary driver mutation. And upon first follow-up, you see how there is a significant reduction in disease burden post targeted therapy. And this is a very interesting classical example how tissue plus liquid gives you a value-added information as compared to tissue alone when you do at the time of disease progression. So this is a case of cholangiocarcinoma with NRAS mutation at the baseline, and the clinician happened to look at liquid biopsy also at the baseline, and there is a documented evidence of how much is the burden of NRAS at baseline. And this patient came back with disease progression after 1 year. And we happened to look at the first follow-up post therapy. and there is a reduction in NRAS clone. However, there is a new clone that has popped up, that is FGFR2 activating mutation, and this turns out to be the value addition that you get from liquid biopsy, which you may not get it from tissue biopsy. So we know that FGFR2 alterations have repositioning options, a level 3 evidence with targeted therapy biomarkers, drugs. So this is one example. Another example I just want to highlight here, the how much of tissue gets into circulation at baseline. So you might see a significant burden of tumor because you are excising, as it was previously mentioned. You have to circle the tumor containing areas, therefore it becomes enriched with tumor. So you would get to see a high allelic burden. However, when it comes to liquid biopsy, it is like a needle in a haystack, right? So there is significant dilution of the tumor molecules, tumor DNA molecules, which have the mutation. Therefore, you tend to see a lesser burden. Here again, not all clones would have a similar proportion of dilution. Some clones might be diluted 1/3 or 1/10, and some of them would be 1/4. So it varies from it. So this is what is all about the tumor dynamics. Quickly on the assay validation on the solid tumor panel, we were able to go to the limit of detection of close to 1% for EGFR mutations. The audience and the interest of the session being non-small cell lung cancer. I'm not getting into the other details here. And this is the another interesting and a very exciting evidence that we found out that not just in CGP, that is the 1200 genes, where we looked at horizon reference standard. Horizon reference is a NIST traceable reference material that looks at all the clinically actionable mutations in cancer at multiple mutational burden. And if your assay is good and you are able to pick up molecules like 1 in 100, that shows that sensitivity is good. Technically, the assay is working. Not only that, I want to draw the attention below here, where we have gene fusions from ROS, RET, and even MET amplification and NMIC amplification. We were able to pick this up on liquid biopsy. And this is just a comparison of performance metrics of the assay at the analytical level. I want to be, reconsidering that it's only analytical. It cannot be clinical for liquid biopsy. And put together, we have a very small study that we did across in this last few months, where we looked at multiple cancer types, both at liquid baseline and baseline tissue as well as liquid biopsy. This is a biased approach because the sample size is very small. However, it's just a sharing here in this forum. What we understand here is the complex biology of the disease across different cancer types is one of the primary factors that defines the concordance between tissue versus liquid biopsy, since not all tumors would release circulating cell-free DNA into circulation in the same fashion. And so the success of precision oncology or targeted therapy depends on how well and how holistic and how comprehensive we are in understanding the molecular spectrum of the tumor. And it depends upon the tumor's biology, of course. Tissue biopsy remains the gold standard. However, liquid biopsy can be used as a complementary tool in clinical practice. And having a combined approach at baseline and subsequent follow-up by liquid biopsy helps in a better management of the disease as per the evidences from the literature. Thank you. And if there are any questions, I'd be happy to take.
Yeah. Thank you, Vidya, for an excellent talk. Like no tissue, no issue. Liquid biopsy is there for your support. So this talk is open for the questions.
Thank you, Vidya. Excellent talk. So I think, as you rightly said, liquid biopsy is a complementary test to tissue biopsy, and we're not omitting tissue biopsy for sure. But what about the frequency of liquid biopsy during treatment and on follow-up? What do you recommend? The frequency of liquid biopsy has to be done every 4 weeks, 8 weeks, 12 weeks. What is your recommendation?
So there are a few studies. There are a few studies which have shown that impact of chemo and radiotherapy on ctDNA burden. So at what time point one has to look at liquid biopsy? There are two ways of looking at it. If we want to define rules, then there is one way. Another way is when the clinician feels that clinically there is a disease progression and he wants to address that without going for an invasive procedure, then liquid biopsy. That is, I think, the commonest approach which most of the oncologists take. When there is disease progression and patient is unwilling to go for another biopsy and he wants to change the management of the disease, then he would go for a liquid biopsy. Another approach, or rather, if you want to understand it more scientifically in the biology standpoint, how a given intervention will have an impact on ctDNA yield, and are we able to detect that in circulation or not? There comes the defining rules of when to sample for liquid biopsy. Ideal way is just before you start the next chemotherapy cycle, there you have adequate impact of the previous therapy onto the patient's disease. Therefore, if you want to understand the current dynamics of the disease, before you want to start a new intervention, you do it just before the new intervention. Therefore, you know the current nature of the disease. That is what many studies have indicated. And of course, other factors also plays an important role. That is the patient's WBC count would have an impact on the overall cell-free DNA yield. And that will again indirectly impact the ctDNA yield. So minimal requirement in most of the NGS assays is 100 nanograms. In general, with a 5 ml plasma, we would get somewhere around 100 ml, 100 nanograms of cell-free DNA in a metastatic presentation. However, if there is a pancytopenia in the patient, the yield would come down to 30 to 40 nanograms. So that would impact the sensitivity of the results, or rather the false negative rate that we would expect to see in the patient sample. In that scenario, how do we overcome? We need to take more blood sample. That's one way, because if we are looking at one mutant against 99 wild type, your representation for 100 nanograms should come from much larger volume of plasma, because your plasma yields are low. Is that answering technically and scientifically, Amit?
Yeah, great. Yeah. So another question to you is that we also encounter scenarios like pseudo progression and true progression on immunotherapy. Will liquid biopsy be helpful in those scenarios?
Well, honestly, I don't know about it. Honestly, I don't know about it, because clinically we have to do that by ourselves. Like somebody has to really look at the liquid biopsy when there is a pseudo progression, because what I understand from the clinic is even though there is a pseudo progression, the clinician doesn't stop the disease intervention management. They continue with the medication. They know that at the end of 3 months or 2 months, depends on patient to patient, they would see a pseudo progression. They will wait for 6 months before they want to see a proper outcome measurement to be done. And if one has to do it, I think they have to do it in a controlled manner to understand what's happening in pseudo progression, probably. Yeah.
Yeah, Dr. Amit, as you have said, as far as lung cancer is concerned, I don't think pseudo progression is an issue in lung cancer. That is more when you are dealing with a melanomas in which you are giving anti-CTLA4, you are giving ipilimumab drug. So in lung cancer, if there is a progression, you have to take it as a progression. That's what we have learned in our tumor boards.
Okay.
So that's not an issue in lung cancer, very, very rarely.
Okay. We did come across one case like that where pseudo progression was there in a small cell lung cancer while profiling. Means that the indication was mentioned pseudo progression on immunotherapy, and there is a fear because already small cell disease is having poor prognosis. Patient lives less time, right? So that's when I think the doctor wanted to do a biopsy and quickly check what's going on to look at new alterations. So that's but in non-small cell probably that's not a challenge at all.
Even if we are anticipating or if there is a dilemma, but eventually it turns out to be a true progression rather than a pseudo.
Okay, sir. Thank you.
So Vidya, I'm Dr. Mehta. I'm online. Hello,
Thank
can you hear
Vidya.
me?
Next, I call upon Dr. Trupti Pai, who is an associate professor and consultant. I should call her as a molecular pathologist as well, because she's actively involved in our molecular tumor boards. So she will give a talk on role of fusions and ctDNA of lung cancer patients in clinical practice. A very good morning to all. So my job is very simpler, as the previous talk has in detail covered a lot of, all the aspects of the ctDNA analysis. So in this talk, I will be, the plan of my talk will be, I will be just going through few slides showing how there was a paradigm change in the lung cancer diagnosis as well as management, few points on the gene fusion, various platforms, then the pre-analytical factor, which is very important when you deal with ctDNA analysis. And then finally, the few studies in literature who have documented fusion gene in ctDNA in lung cancer. So we all know how there is an evolution of lung cancer care. In early 2000, the broad classification of lung cancer as small cell versus non-small cell would suffice. Then came an era where you need to histologically accurately classify adeno versus squamous. And now is the molecular era where you need to pinpoint which exact molecular targets are present in a particular case. So for each histology-based subtypes, there are different spectrum of molecular targets. And now there is a ever increasing list of FDA-approved drugs. So this makes it a point that the molecular characterization has to be performed using highly sensitive, specific, adequate, and validated tests. No matter what tumor samples, histology, cytology, cfDNA, low percentage of tumor cell, what is the answer? You have to provide a molecular characterization of a tumor. So what is the, so how do we go about it? So multi-gene testing, that is the NGS panel, which should encompass must test biomarkers, should test biomarkers and other investigational biomarkers. This should be your panel when you deal with any multi-gene testing. So coming to fusion genes. So what are fusion genes? Fusion genes are basically juxtaposition of two independent genes which come together, and following which there is this driver mutation, this driver gene, molecular driver, which stimulates the downstream signaling pathways. So for a fusion gene, it can be either a translocation, deletion, inversion. It can be within a same chromosome or within a different chromosome. So when it comes to lung cancer, we have many success stories of fusion genes, that is ALK, ROS, RET, NTRK, with ALK, which is seen in about 2 to 7% of NSCLC cases. And now we have like a progression-free and overall survival as close as 5 years with this ALK TKIs. Same holds true for ROS, which is seen in about 1 to 2% of lung cancer cases. And you have around 25 to 30 types of gene fusion partners for ROS. So the ROS TKIs like crizotinib and entrectinib, the latter with a good CNS permeability. So it is very important to identify all these fusions. RET fusion with the commonest partner being a kinesin family. And you now have this FDA approval for this selpercatinib and praseltinib approved for RET fusion genes. Same hold true for NTRK. You have NTRK 1, 2, 3 fusion genes, and you have different TKIs for this. So with this development and approval of new drug targeting all the rare fusion, it is very important that you do deep molecular characterization of lung cancer specimens. So when it comes to platform of detection, you have single gene based testing and multiplex testing. With fusion for ALK and ROS, single gene based testing is fine. Like you have very well established IHC markers and FISH. But for RET, NTRK, the only answer is multiplex gene testing and next generation sequencing. So I will spend some time on this slide. So NGS for fusion analysis. When you look at this, you will divide it into various types. So first is how do you analyze, level of analysis, whether it is RNA based or DNA based. Our DNA we all know is very stable. So when you use DNA based analysis for fusion testing, apart from fusion, you also get other details like you get SNVs, copy number variations, MSI, all other details is possible. The only thing when you use DNA based thing is if you have multiple breakpoints at the intronic region and you have large deletions, it won't be able to pick up by this DNA based. As against RNA, RNA is very sensitive for any fusion genes. You will be able to identify and quantify the fusion transcripts irrespective of where is the breakpoint in the intronic region. However, RNA is very unstable, very impure, especially in diagnostic settings when you are dealing with FFP samples. So you have to be very particular about your quality checks before you start with any NGS for fusion analysis. Another thing is what is your panel target, whether it is a limited gene assay or whether it is whole transcriptomic or genomic. Secondly, when you look at the chemistry of the sequencing or with the library preparation, so whether it is hybrid capture or amplicon sequencing. So hybrid capture with the help of specific probes, you will target the entire gene of interest. So that is very good when you want to design large gene panels. It also helps you to identify known as well as the unknown fusion partners. So it is very good. It can be used in RNA as well as DNA. But when we are looking at the amplicon based sequencing, so in amplicon based, you will amplify the region of interest. It is mainly pertinent to RNA based testing. And you should have the known and known partners when you deal with amplicon based sequencing. Another is sequencing chemistry, whether you are using ion torrent or sequencing by synthesis chemistry, that is Illumina. Another thing is then depending upon the bioinformatic pipeline. So all these parameters are very important before you test for any fusion gene analysis. We should be aware of this chemistry and these technicalities. So all this is very well established in the solid tissue. However, as we all know, like majority of the cases, like 60 to 70% of lung cancers are in the advanced and metastatic stage. And the only available tissue with you is a biopsy, which is also barely representative of the intratumoral heterogeneity. Also up to 10 to 20% of biopsies are inadequate. So what is the solution for this case is the non-invasive alternative, that is the cfDNA. So when it comes to cfDNA, what are the recommendations? Whether the patient is treatment naive or on progression. So for first and foremost important for newly diagnosed patients with advanced NSCLC, plasma ctDNA is a valid tool wherein results are often complementary to tissue analysis. Directly, you cannot start with cfDNA. However, at baseline, if the tissue is inadequate or inaccessible, you can start with this. At the time of acquired resistance, however, the guidelines say that the plasma first approach is preferred, and only if negative, you can do a repeat tissue biopsy. And testing for plasma ctDNA should be performed using a clinically validated NGS platform and not to use single gene based PCR approach when we are dealing with this. So with this, I will highlight few important points on circulating tumor DNA. So what is circulating tumor DNA? It depends upon the necrosis and apoptosis of the tumor, and then the tumor cells are shed in the circulation. The fraction is very low. So it is less than 0.1%. And also the DNA fragments that are released are very small and they have a half short life. Now, why this is important is that, so like finding a needle in the haystack. So few points on the pre-analytical parameters, like when you take the sample, whether you are using a EDTA tube or using your STREC tubes. So when you are using a STREC tube, up to 3 days, it's fine at room temperature. But when you are using EDTA tubes, you have to extract the plasma within 2 hours. Otherwise, what happens is that there will be degradation and there will be further dilution of your tumor DNA with the wild type DNA. Another thing is how do you process? You should not freeze the blood sample. Then the spinning should be very fast double spin when you want to extract. So why this is important? When you want to extract cfDNA, this double spin high speed centrifugation is must. Whereas if you want to extract RNA, you should not use STREC tubes, and also there should be no high speed centrifugation. It should be a platelet rich plasma. So all these points are very important from technicality before you interpret any case as positive or negative. Other thing, of course, the depth of sequencing and what technique are you using. So when it comes to ctDNA, what is the main issue is the low sensitivity, but definitely a high specificity of the. So what is like low variant allelic fraction? Even if 0.2% allelic frequency, will consider it as positive. Another thing is contamination with the wild type DNA. You have this chip issue, that is the clonal hematopoiesis of indeterminate potential. All this thing, there is very inconsistent shedding of tumor DNA. Majority of patients will have very low tumor DNA. So comparatively, everything you have to take into account before you deal with analysis of cfDNA. So coming to the gene fusions on plasma samples. So in literature, so in our lab, we are not doing gene fusions on the plasma samples. So whatever I will be showing is a data which is published in the literature. So different NGS panels have been used. So mostly they use this hybrid capture panel. So whatever is the majority of the studies, they make use of this Garden 360 and Foundation 1 liquid. So both these panels are hybrid capture. They have around 70 gene panels, of which has SNVs, CN copy number variations, and fusion of approximately 6 genes. Also, they have some indels analysis in some of these genes. So this is one of the largest prospective study which was done on the cfDNA NILE study, that is the non-invasive versus invasive lung evaluation. So in this, they had taken biopsy proven previously untreated non-squamous metastatic NSCLC over a duration of 2 years. And what did they demonstrate is that, so there were some cases which they did upfront tissue and also cfDNA. So overall 95% patients were fully assessed for all 8 guideline recommended biomarkers in cfDNA. So 268 cfDNA sample versus 51 tissue. So that is a very huge number. So 48 cases were positive for the mutations in both tissue as well as ctDNA. The positive predictive value of the genotyping in cfDNA was 100% with a greater than 98.2% concordance. And now the important thing is, when the primary modality was tissue based, only 67% of the patients were identified by tissue as against 87% when cfDNA was used as a primary modality. So this study demonstrated the non-inferiority of cfDNA based versus standard of care tumor tissue based genotyping. So this was a very important study, NILE study. And most importantly, the TAT. It was around 9 versus 15 days. And when it comes to NGS, TAT is a very important key quality metric. The second study was the clinical utility, where they just looked at the ULK gene rearrangements in the cfDNA. And they found that it was a study of around 90 cases of ULK gene fusion, and they were able to identify fusion partners. Then even some cases, the tissue was insufficient. but cfDNA had good results, and follow-up of 3 of these 5 tissue negatives showed response to ALK TKI, which is again an important. With cfDNA, they were able to identify this ALK resistant mutations because it had all DNA based variants also. And in 6 patients with known EGFR mutation, ALK fusion was identified on progression in 5 of these cases. Similarly, there was a Chinese study. Again, they used a different panel targeting 168 genes using 50 nanogram of ctDNA. And it was blood samples from 24 ALK gene rearranged, and they were able to identify in 19 out of 24 patients with a baseline specificity of 100%. So with all these studies, we see that though the sensitivity is lower, but specificity is 100%. And so there were also few studies which didn't use hybrid capture, but also amplicon based sequencing on ion torrent platform. So again, the same with a very low nanogram, 10 nanogram of ctDNA, still a specificity of 100%. The other thing when it comes to ctDNA is depth is very high. It is around, so if in diagnostics samples in tissue, if you use a 500x coverage with ctDNA, it is 5,000, 15,000, and what some studies have published like around 60,000 depth coverage. So that is what is very important because of very low allelic fraction of the target in this. So to conclude, gene fusion analysis is crucial in the context of lung cancer precision medicine. NGS presents several advantages, and it allows the analysis of more targets, saving time and material if the turnaround time is acceptable. So clinical relevance of ctDNA is now well recognized in all stages of clinical evaluation. But in spite of this interesting available results, the real utility in clinical practice when it comes to fusion has to be assessed on the large scale studies. And what are the two main challenges is to have a standardized assays for fusion and to translate these observations into clinically useful test. This I would like to end my talk. Thank you. And I would like to thank all the organizers.
Thank you so much, Trupti, for highlighting the features and challenges in liquid biopsy. This talk is open for the questions. Any questions from the audience? Okay, thank you, Trupti. Yeah.
No, you mean for fusion? Yeah. No, we are not using fusion. We are using amplicon based in our RNA base. That is why we are not able to assess the fusion gene. Yes. So why we are not able to use so that we are yet to validate. We have not yet. So the panel that we have is not acceptable for this analysis. So that is the thing. So what we are using here, we have hybrid capture for DNA based variants, but the RNA that we are using is amplicon based sequence. That is why with this cfDNA, we are not able to assess.
Okay, one more question, Trupti. You mentioned about the Streck tubes that they don't pick up the RNA fusions. So what about the samples coming from outside? Because for the transportation, we need to use the Streck tubes. So
no, I mean cfDNA can be extracted, RNA.
Yeah, if it is a RNA based, your test is there.
EDTA is fine.
Yeah,
tube is specifically not
but again, for the transport, it takes around 48 hours. So do you reject those samples if they come to you in the Streck tube, if it is the RNA fusion based test?
So, ma'am, as I said, we are not
doing.
RNA
Okay.
based test. So right now, whatever we are getting is from outdoor stations. We are getting Streck tubes, and we are doing cfDNA. So that is fine.
Okay.
If there is no access to Streck tube, can the any lab or the person can separate the plasma and send it to you? Is it possible? Is it allowed?
Yeah. So the
That is
thing
acceptable.
within 2 hours, you have to extract the plasma.
Separation, and then what is the stability in the plasma?
You mean that you have to keep in the fridge. Before plasma extraction, you cannot freeze the sample. After that, you can.
But what is the shelf life? 3 days, 5 days stability?
That I may not be able to tell you after extraction how much it is.
Okay.
Because it will take.
Yeah, because by the time it reaches, yes, then plasma won't be useful. Thank you, Trupti. Next, I call upon Dr. Pratik Chandrani, who is a who is a PI and assistant professor in Tata Memorial Hospital and a well-known bioinformatician. He has developed his own cleanome bioinformatic analysis. So he's going to talk on comprehensive NGS testing and its data analysis in oncology at TMH experience. Dr. Pratik. Pratik, are you not ready still? Or I can take next talk. Dr. Anurag Mehta is waiting.
Yes, I think
Yes.
I
Yeah.
will be happy to take it because I have to go back to the
Okay.
office.
Welcome,
So if-
sir. So
thank you
here is
so
Dr.
much.
Anurag Mehta, Director, Rajiv Gandhi Cancer Institute and Research Center. We always enjoy his talk. So he's going to talk on NGS, pulling back the curtain on the what, why, and how of variant allele frequency in clinic. Over to you, Dr. Anurag Mehta.
So thank you, Anuradha, and morning to everybody. And I'll be speaking today to you on variant allele frequency, which is a core element of an NGS report on a variant. How do we arrive at this variant allele frequency, and what inferences one can draw from this variant allele frequency are the 2 points that I will discuss with you. So in the last decade or so, NGS has emerged as a workhorse for comprehensive molecular testing. And while NGS can look 360-degree for genetic alterations, the most robust usage of NGS is for mutation calling. And we all know mutations are the result or the events that result in changes in the genomic DNA. And these mutations can be point mutations, or there can be alterations in a few nucleotide, what we call as a multinucleotide variants, or there can be insertions and deletions up to 50 base pairs, which are called microindels. And these mutations are divided into variants. Variants are the deviation from the human genome reference sequence observed in one specimen. And these variants have to be annotated for clinical significance, for actionability, and for seeing whether they are heralding an evolving resistance. And then we have a term called polymorphisms, which are the mutations that occur in a population at the frequency of greater than equal to 1%. So this is a population-based information, and the polymorphism lack perceptible impact, though they can have covert impacts. Now, how do we quantify variants and polymorphism? So there are a variety of terms which are used, and they're confusing. So there are 5 terms like variant allele frequency, variant allele fraction, fractional abundance, mutant allele frequency, mutant allele fraction, similar sounding, and they all mean same. And then we have something called allelic ratio, which is dissimilar sounding, but which is somewhat similar to variant allele frequency and synonyms. And then we have minor allele frequency, which is similar sounding, but has a completely different meaning. And I'll explain to you what do these mean. And please remember that it is better to use fraction to quantify a variant or a mutation in one sample, and it is better to use frequency in population statistics, though this is hardly used in practice. So let's take an example here of how do we calculate these. So this is a result of a next generation sequencing. 750 reads have been obtained. These have been downsampled in this picture to 15 tracks. And of these 15 tracks, when they have been aligned to reference genome, 9 have been found to be of wild type, while 6 of them shows a mutation from T to C. So when we resize them, the wild type reads will amount to 450 reads, while the variant reads will be in 300 reads. And if we divide this 300 by 750, that is the mutant reads or the alternate allele divided by the mutant reads plus the wild type reads, what we will get is called variant allele fraction or variant allele frequency. Now, what is allelic ratio? Allelic ratio is somewhat similar. Here we have in the fraction, the numerator of the mutant reads divided by the wild type of reads. It's not the sum of the wild type plus the mutant reads, but just the mutant reads divided by the wild type reads. So in the same example, the allelic ratio will be 67%. Now, there is only one instance where allelic ratio is used for reporting, that is used in FLIT3 ITD. And in FLIT3 ITD, it is said that an allelic ratio of 0.50 without a co-occurring NPM1 mutation portends adverse risk, and the best benefit of midostaurin is obtained when the allelic ratio is more than 0.50. I also searched for the use of allelic ratio in the literature. There's only one reference where a high allelic ratio of KRAS in pancreatic adenocarcinoma was associated with shorter overall survival. And then we have something called minor allele frequency. Now, this is a population-based index, and this basically refers to how many people in a population group have an alternate allele compared to the major allele. And this is basically obtained by allele detected with a variant divided by the total allele screened. And remember, each individual will contribute to 2 alleles and not 1 allele. So the minor allele fraction, when it is less than 0.001, is considered significant, and those which variant have a possibility of being deleterious or clinically significant. But if the minor allele frequency is high, for example, here 42%, you don't have to struggle with how will it behave. You know these are benign. Similarly, another one with 19% will automatically be benign. Something with a 6% will automatically be benign. So this minor allele frequency actually helps us in easing how to call a mutation. And then we talk about the variant allele frequency a little more. Take this example. Here we have a tumor fraction of 60% and normal tissue of 40%. And this is from lung. And while the NGS was performed, we found KRAS mutation, G12C, G28 transition was there. So now tell me, what is the expected variant allele frequency, provided sequences has been optimally done? And remember that we are talking about a oncogene. So if we just do a back of a envelope calculation, we have a normal tissue, which is 40%, will contribute 2 wild alleles. So there will be 80 wild alleles. The tumor tissue is 60%. It will have 1 wild type allele, and it will have 1 mutant allele. So we will have 60 mutant allele out of a total alleles of 200. And therefore, the variant allele frequency will be 60 divided by 200, about 30%. And so remember, in a optimized next generation sequencing, the variant allele frequency will be 50% of the tumor fraction. And when it is around that figure, it is a clonal alteration, and clonal alterations are the best for making therapeutic decisions. Occasionally, the VAF will be lesser than the expected, and this is what happens when it is a subclonal alteration, but these can be prognostically significant. Take the example of a renal cell carcinoma. If you have a BAP1 branch mutation or a subclonal mutation or a TP53 subclonal mutation, they portend inferior outcomes, while a PBRM1 may actually mean a better outcome. And these subclonal alterations may also be the first indication of developing acquired resistance to therapy. For example, this 57-year-old with a metastatic colorectal cancer of the left side initially was found to have a wild type of RAS and BRAF, was given biological with a chemotherapy backbone for 2 years. And after 2 years, he showed progression of the liver lesion and a peritoneal involvement. A repeat biopsy again showed adenocarcinoma. and NGS now showed a VAF of 5.3%. So what does it mean? That now this individual has developed a subclone which is having a KRAS mutation, and sooner and later he has to progress. And these can, so therefore they can, these subclonal mutations can be used for abandoning a therapy, and they can also be used for selecting a therapy. For example, T790M, one can shift from first generation, second generation EGFR TKI to osimertinib, or for example, G2032 in ROS1, where one can then shift from crizotinib to lorlatinib, etc. And occasionally we can have a variant allele frequency which is higher than the expected. So here is a case of a 56-year-old who has an EGFR mutation and was being treated with osimertinib. 13 months later, he started showing signs of progression. An NGS was done on a metastatic tissue. When his initial NGS was done, he was found to have a del19 with a variant allele frequency of 40% and a tumor fraction of 90%. But now when we did the NGS, the del19 was found at a variant allele frequency of 73%. Can you guess why is this variant allele frequency so high? So, well, this variant allele frequency was this high because there was EGFR copy number game along with the MYC amplification. So the copy numbers were 5.15. and the del19 was seen virtually in all the reads. So what could be the clinical implication of that? It has been shown that the individual with a high VAF tend to respond better to the targeted therapy with a longer PFS. This was shown in one study. However, the other study showed that there is truly no benefit in PFS, but the higher number of objective response rates were obtained in those cases who had a higher VAF. And then we move on to VAF calculation in tumor suppressor gene. And this is a whole new ball game. So we all know then when a tumor suppressor gene is involved in oncogenesis, there is initially a monoallelic loss of function mutation or a small deletion. And decades later, there is biallelic loss, which can happen by a deletion or by uniparental disomy, where the normal chromosome is lost and the abnormal one is duplicated, or by a new mutation developing in the same gene. And each one of them will show a different VAF. So here we take an example of a tumor fraction of 50% and normal tissue of 50%. The alteration is deletion on one chromosome and mutation on one chromosome. So if we just do again a bit of calculation, normal tissue will provide 2 wild alleles. That means 100 units will be obtained from the normal tissue, and the tumor tissue will provide 1 mutant allele because the other one has been lost. So there will be about 50 mutant alleles. So that means the VAF will be 50 by 150, about 33%. And it is always higher than the half, which is unlike an oncogene where it is nearly half. Now, so an example, 50% tumor fraction, 32.112% VAF. And then if there is a uniparental trisomy, we will have a normal tissue contributing to 100 wild alleles, and tumor tissue which will also be contributing to the 100 mutant alleles, because both alleles are mutant, and therefore a VAF will be around 50%. So this will have the highest VAF. And when there are 2 different mutants, then each one will have a VAF of 33% each. And then we come to a real life example, a 36-year-old with a high-grade pleomorphic soft tissue sarcoma. The tumor fraction is 50%. The normal tissue is also 50%. The TP53 shows a loss of function mutation. The variant allele frequency is 80%. So how can such a high variant allele frequency be explained? This is even higher than what one will expect with uniparental disomy. So remember, this may be because of polysomy the chromosome 17 has made many copy. But it is also important to remember that this could be because of germline mutation, because one germline mutant allele is being contributed by normal tissue also. So you have a 50% from the tumor and 25% from the normal tissue. So that will take it up to 75%. So high VAF are associated sometimes with germline mutation. And in the context of a young patient, and you have to take this family history. Here was a supporting family history of a younger sister with an ALL. And this TP53 is a high-risk cancer predisposition gene. So therefore, a germline testing is recommended. And this is the recommendation of the ACMG. With high variant allele frequency, there is a greater likelihood of a variant being germline. However, it is not recommended to exclude or confirm germline origin based solely on the variant allele frequency. You have to take into account the affected gene. And these is the list of gene where if you find high variant allele frequency on somatic or tumor testing, you have to carry out a germline testing. And many manufacturers are providing germline testing for genes even beyond the list given by the ACMG. So once you have a very high variant allele frequency, the slide we began with, we generally add a note. We say that kindly note that the variant detected in this particular gene has a high variant allele frequency in relation to the tumor percentage of the limited submitted block, indicative of a possible germline BRCA1 variant here or that gene variant. Hence, it is recommended to confirm the same on a peripheral blood sample of the patient. So to summarize, variant allele frequency is an estimation of the abundance of the mutant allele. It helps separate a clonal oncogenic driver from a subclonal alteration. VAF can provide an indirect inference of copy number alterations. VAF may provide insight into the mechanism of loss of function of alteration in a tumor suppressor gene. VAF can also help seek out germline mutation from tumor testing. And VAF is used in the laboratory for setting up limit of detection assays, as was spoken by Vidya in her talk. So thank you so much. I finished with that. And if there are any questions, I shall be happy to answer.
Yeah. Thank you, Dr. Anurag Mehta, for educating us on the VAF, where we experience on the day-to-day NGS reporting. So the talk is open for the discussion.
Very nice talk, sir. Sir, I wanted to know in your day-to-day practice, how many times with high VAF without having any EGFR amplification or any alteration, do you ask for reflex germline testing?
No, we basically ask, like EGFR, of course I won't, because EGFR, except for a very rare instance of T790M, is the only one which can have a germline presence and can cause inherited lung cancer. So in EGFR, I won't. I will restrict myself only to those high risk genes where the VAF is high. I think there has been about 8 or 9 occasions when we, on the basis of a somatic high VAF, have been able to pick up a germline alteration.
Okay, sir.
Hi, Dr. Anurag, Dr. Amit here. The implications.
Go ahead, Amit.
Hi. Implications of VAF interpretation in accordance with the loss of heterozygosity. If, like in ovarian cancer, we see LOH, what is the implications in the VAF reporting?
So actually, when you are doing a somatic testing, and unless you can confirm that the VAF is more than 10% at least, because otherwise sometimes it can be because of the error of sequencing or PCR, etc. And if you can, unless you can confirm it is matching with the biallelic loss, though of course there are no guidelines, the studies where the olaparib and rucaparib have been approved, etc. They have, at least for the olaparib, they had used the biallelic loss, but the rucaparib had not, and that is why rucaparib had shown a lesser benefit compared to olaparib in their study. So you must use WAF actually speaking to find out whether it corresponds with a biallelic loss or not. Unfortunately, the guidelines do not include that.
Thank you.
One more question, sir. So what is the
Yes.
cutoff of WAV that you use for your NGS testing?
So we report limit of, we report 5%. That is the our LOD. No, but not for the liquid biopsy, but for this somatic tumor testing, 5%. But there are occasions, for example, when the quality of read is very excellent, integrated genomic viewer shows us excellent clean reads with a high mapping score and FRAD score. And this portends, this is of prognostic significance, we include that.
Sometimes the tumor percentage is high and you get a canonical variation which is less than 5%. For example, you get a typical EGFR exon 19 deletion, which is just 2.5% with a high tumor fraction. So how do you go about reporting in such cases?
We repeat the test.
Okay.
Dr. Mehta, this was very good. This was an excellent talk and a very good introduction into the VAVs. This is Amit Dutt from ACTRAC.
Yeah, Amit, how are you? I remember having met you. Go ahead.
Thank you. I'm good. I was just wondering that striking the chord for germline testing, I mean, has its own consequences based on these reports. Especially when with regards to, as you mentioned, with regards to the tumor suppressor genes such as the BRCA1 or P53, when the VAFs are at a higher side. Do you also consider about the copy neutral LOH as one of the reasons before mentioning in your report whether this could be primarily something advising for a germline testing, because that could be something which is very frequently that is observed and more often than the germline contribution?
So copy neutral LOH basically will not trace the VAF. So you cannot make that decision based upon that VAF to request for a germline testing.
Right. The copy neutral LOH would lead to a higher VAF, right? Where the mutant allele is replicated and it's
so that's what I said. You know, so uniparental disomy will lead to higher VAF, but these VAF, when it is associated with germline, are actually higher than the uniparental disomy also.
Right. I mean, so that was something that because usually you tend to get to see in these reports with these genes with variant VAFs. So these are the questions that usually that people kind of like start pondering in a tumor board.
So that's what I say, you know, at least you have this idea that the LOH can be because of one deletion, because of uniparental disomy, or what you called as a copy neutral biallelic loss, or because of two mutations. I think you shall have a back of an envelope calculation quickly done. And if you are exceeding the expected VAF, probably that is a case where, and especially for a Lynch, if you have a MSI in a BRCA, you have a family history.
Yes.
For TP53, you have a family history. Then I think you shall go ahead and ask for a germline testing. Germline testing in TP53 should not be asked unless there is other supporting evidences. Absolutely. So I think there is a nice paper by ACMG, which I had actually alluded to in my talk. So use that template, and you will know that there are 5 or 6 situations where you shall actually ask for germline testing with high somatic VAF.
Right. That's what I was kind of like alluding to as well. So I'm continuing to the question that what Trupti was asking with regards to the detection. I mean, the LOD that what you mentioned. Usually these depths are 250x or higher or even 500x. Why would you still have the cut off at 5%, because anything at even at 1% would be very significantly represented in the reads. So I was just wondering, you already mentioned that based on the read depth, you do change your paradigm or the threshold of calling it to be a mutant. But if your comments on that.
So if you will look at the match NCI trial, and I always use match NCI trial as my template for quality metrics. The match NCI trial requires 25 reads, good reads with a reasonable Fred score to make a call. And at a 5% LOD with 500x, you will get 25 reads. Now, the point is, in an oncogene, you want at least, you want half the tumor fraction to call it, as an oncogenic driver there. But we can make a call always. We do make a call when we get 25 clean reads at 500x. Uh, that's how we make a call. Actually, we do make a call, but whether that call can be used for therapeutic decision making or not will be and shall be discussed in a tumor board, in a molecular tumor board.
Yes, so I was not aware of this 25 reads. I mean, that is kind of like a strong basis of like with the 500x to do that. Yes, thank you very much for this information.
Yeah, so I think you can take up the NCI match trial. NCI match trial clearly says 25 reads. The Thermo Fisher manual says 20 reads, but I think it's better to be a little more stringent. Go to 500x, get 25 good reads, and then make a call.
Right. And maybe finishing with the comment is like people usually tend to get confused between you already mentioned to this with regards to the VAFs in the tissue biopsy and the liquid biopsy, which is a completely different ballpark when it comes down to the liquid biopsy. You have already mentioned it, but I just wanted to kind of like re-emphasize.
Yeah, so liquid biopsy, actually, we have the families. So UMI families, and we report those molecular families rather than the VAF. And I will not suggest that we can use them for quantification. They're primarily for determination. That's a very determination or identification of a mutant. And that's a different ball game altogether.
Thank you, Dr. Mehta. Always a pleasure listening to you.
So, Dr.
I have a question. Good morning, sir, and a very nice presentation. As you said, we are blessed to have you. Sir, I want to ask you one thing. So this is regarding the germline testing. And could you just address the topic of mosaicism? Because there are at times very low frequencies of some mutation we find in germline testing. So how do we go about it? So can you throw some light on that?
So mosaicism basically has been associated with a lot of non-cancerous diseases. Neurodegenerative disorders are often associated with mosaicism. Mosaicism basically alludes to a mutation developing at a zygote or a 2-cell or a 4-cell stage with 25%, 12.5%, 6.25% of the body cell carrying that somatic mutation. That will be called somatic mutation and not a germline mutation, because it has not come from the ovum or from the spermatozoa. It has developed at the zygote or subsequent to the zygote stage. So those kind of somatic mosaicism have been associated with neurodegenerative disorders and have also been associated with some kind of cardiomyopathies, etc. So I think that's a completely different ball game, but mosaicism is known, and mosaicism should not be confused with germline alterations. It's basically a somatic alteration. And it will only be seen in that 6.25% of the tissue or 12.5% of the tissue that has developed from one of the 8 cells or one of the 4 cells of the blastomere.
So if I may add on that, Dr. Moshmi, I mean, this is congenital, right? So as what Dr. Mehta is also alluding to, how does this really relate to the VAF? Because the VAF would still be like a germline in those tissues.
germline testing. So the VAF you are expecting if there's germline testing, it should be around 50%. But like if something is coming less, so should we suspect mosaicism? That is what I'm trying to ask.
No, you shouldn't. No, you shouldn't, Moshmi, because the point is this. This is somatic. So like you have fibrous dysplasia, polyostotic, involving one leg. So that's like 12.5% of the body cells had this alteration at the 8-cell stage. So if you look at a tumor tissue, you will probably get that kind of additional VAF, but you won't get that confirmed by doing a test on the blood or saliva.
So, Dr. Anurag Mehta, Pratik Chandran here. I have one question regarding well-known germline alteration, say BRCA. If it is observed at about 50% frequency in non-breast cancer, how comfortable are you to call for a germline testing and further investigation?
Which one? Which gene did you speak about?
So I'm talking about BRCA1 and BRCA2. In
BRCA1 and BRCA2,
non-breast cancer.
You said 50% frequency?
50%, correct.
So if I find 50% variant allele frequency, will I go ahead and ask for a germline testing or not?
Yes, yes.
Is that your question?
Yes.
So I will ask for a germline testing.
So do you recommend germline testing irrespective of familial history? Just
in high risk, in very high risk genes, yes. Okay. I will not do it for TP53. I may not do it for STK11. I may not do it for CHEK2. I may not do it for ATM, but I will do it for BRCA1, 2, and I will also do it for all Lynch genes.
Okay, thank you.
Thank you, Dr. Anurag Mehta, for a very interesting interaction. Thereupon, I call Dr. Pratik for the next talk.
Very good morning, everyone. Today I'll be talking about computational genomics and comprehensive genomics in clinical applications. So we all know cancer classification has undergone a paradigm shift already, and we have moved on from organ-based classification to histopathological to the era of molecular classification today. And in this molecular classification, we want to identify the therapeutic alterations which are driving the tumors, and these drivers are further targeted by small molecule inhibitors specifically designed for those alterations. Furthermore, we have seen that several different therapeutic targets have been reported all across the world, and all of these targets are to be incorporated in a clinical practice. So how it usually goes is that a patient sample is received in the clinics, which goes for targeted NGS testing, and this NGS data is to be analyzed by computational tools, and that generates a report of therapeutically relevant alterations, and this report goes to molecular tumor board. In this report, what we are looking for is to classify different kind of point mutations, indels, copy number alterations, gene expression, fusions, as well as pathogens to be classified into whether it is having a non-clinical significance and association, or whether it is falling into unknown clinical significance, or VUS. For all of the variants of non-clinical significance, we further look at whether FDA and other global body approvals are in place, or whether there is any other prognostic significance, and so and so. Now, to do these, sorry, what we have to do is either go for sequential NGS testing. As you can see here, for lung cancer, we have been doing for quite some time now. Since day one, we go for EGFR testing, and then after a week or two, we further go for ALK, ROS1, REST, and if all of them are negative, then we go for MET and so and so. So this usually takes about 30 to 40 days for analysis of 7-8 different biomarkers. biomarkers in lung cancer. Instead of that, if we go for comprehensive genomic profiling from day one in the patient, then within a week we get to know what is the mutational landscape, and that saves a lot of time as well as tissue. Now, coming to the tissue, how that is actually helping. So each of the individual assay that we perform in the laboratory requires roughly about 3 to 8 different sections of FFP block, and combined together, this entire non-comprehensive genomic assay will take roughly about 25 to 30 sections minimum of a typical patient. If you go for comprehensive genomic sequencing right away, then we can make the same comprehensive information available at the expense of about 5 to 7 sections only. So that saves a lot of tissue, and this can be very critical for cases like lung cancer, where getting a large chunk of tissue is a major problem. Apart from that, we also have to make a conscious decision of which genomic test we want to use, and there are several options available. Here I'm showing you a very small list of the more widely used test available, which includes Foundation One, MSK, Caris molecular test, and Illumina TrueSites. They all range in the order of 300 to 500 genes. And recently, our Indian company Care has launched the 1200 gene panel. Whichever genes we go for, all of these are considered to be comprehensive gene panels. And how these comprehensive gene panels can cover the alterations which are not otherwise picked up. So here I'm highlighting a few of the studies which are showing the total yield of therapeutic targets, and you can see that in this latest study from 2022, which was from Japan, around 23% patients of various cancer types were attributable to targetable therapies. Another study from India, having 297 patients, was showing about 10% of the patients receiving targeted therapy. This number is slightly lower in this entire table, because we know that we have certain resource limitations in the country. But if we look at other countries, mostly data from the USA, we get to see that roughly about 35% to 70% of the patients are attributable to targeted therapies. But these numbers can be very tricky, and these numbers can be very tricky because getting this information is also a big challenge. So here at Tata Memorial, when I was working with Dr. Amit Dutt as a postdoctoral fellow, I developed a tool called Clinome for clinical genome analysis. In this Clinome, the first question we asked was, across the whole genome, what are the therapeutically relevant biomarkers, and how we can catalog all of them in a single comprehensive NGS assay. So we have at present about 175 genes, which covers roughly about 3,000 different mutations, and all of these mutations correspond to 283 different drug compounds, and there are about 26,000 gene to drug relationships in this database. So by building this database, we are now able to catalog what is there actionable, what is available, and how we can take advantage of it. Furthermore, we implement this into various kind of situations. We simulate how this therapeutic report can be interpreted. So say, for example, in this case of lung cancer, if there is a EGFR L858R and T790M mutation detected, then Clinome will recommend osimertinib, and it will also highlight all the drugs which are already known to show resistance because of presence of T790M. In a secondary case, where a lung cancer patient harboring FGFR3 alteration, Clinome is able to recommend a drug called BGG398, which is under clinical trial, and Clinome is also highlighting and giving a URL. One can go to the PDF, click on the link, and they will be presented with the whole set of clinical trial details, and that can be recommended to the patient if it is feasible. In this third case, it is an endometrial carcinoma patient harboring EGFR L858R mutation, which is not a conventionally expected mutation in endometrial carcinoma. In such case, Clinom will recommend you to use Gepitinib and all other EGFR TKI in the off-label setting. It will also tell you that the approval for these drugs and for this mutation are for lung cancer and not for endometrial carcinoma. So this is not a standard practice, but this can be really useful in some rare and challenging cases where no standard options are available. And last but not the least, cancer pathogens have also been shown to have therapeutic implications. Most notably, here I'm showing oral cancer patient harboring HPV infection, which is recommended to undergo aggressively reduced radiotherapy. Otherwise, they have much higher toxicities and all. So that is a level of personalization we can provide even to the non-biomarker driven therapeutic decision making. Now, to make all of these different kind of reports, we have to use a computational algorithm. And while developing this algorithm, we realized that there are several challenges that we practically face in decision making. So how that happens is that we get the NGS sequencing data, which goes through the standard practice, best practice of genomic data analysis, and we identify biomarkers from there. Now, after identifying biomarkers, we need to ask three different questions as shown in these green boxes. And to ask these questions properly, we need to know the cancer type of the patient. Now, say for example, pathologist one would like to call a cancer adenocarcinoma of lung, and pathologist two would like to simply write lung adenocarcinoma. These two texts means same to us, but it doesn't mean the same to computer. When you try to match these two text strings, it will not be identified as the same text string by the computer. So what we do is we use a natural language processing algorithm here, which is a AI algorithm. It takes a different kind of text strings, normalize them, and interpret them, and the interpretation is then matched together. So that helps us identify the right cancer type, irrespective of what pathologist is reporting in their pathological report. So after identifying that proper cancer type, we ask whether biomarker is already known for the same cancer type, whether biomarker is known for any other cancer type for off-label utilization, and whether biomarker is part of any ongoing clinical trial. Now, at this stage, again, we have to consider the cancer type recommendation from the label recommendation, whether it is coming from FDA or any other organization. There also, again, the text strings are mentioned in a different manner. So, for example, EGFR, erlotinib, and gepitinib recommendations are always identified as non-small cell carcinoma positive patients. And nowadays, we don't use non-small cell carcinoma terminology. We directly classify a lung cancer patient as adenocarcinoma or squamous cell carcinoma or small cell directly. So this adenocarcinoma terminology will not be found on the label. So how will you match a label with your cancer type, which is coming from your pathologist? So we developed another AI tool, which is completely in-house designed at the Tata module. We call it tumor type tree or T-cube to call it short, where we phylogenetically in a child-parent relationship wise, we link 800 different cancer types, through which our AI algorithm is able to understand that any label approval for non-small cell carcinoma will be equally applied to all the child terminologies within non-small cell carcinoma. And because of that relationship awareness at the computational algorithm level, Clinome is able to recommend EGFR TKI irrespective of what child classification of lung cancer you are recommending, irrespective of label complexities and so on. So this is able to sorry, this is able to get rid of these anomalies that we get to see when we are trying to match label with the current practice in the field. Moreover, it is also able to take care of tumor agnostic and tissue agnostic drug recommendations. And to our knowledge, this is at present the only tool which is able to do so, which is available open source. Say, for example, NTRK is recommended for all the solid tumors. Now, when we say all the solid tumors, as a human being, we know what all comes under the umbrella of solid tumors. A computer doesn't know the same thing. So by using this tumor type tree relationship, our clinome is able to understand all the cancer types irrespective of what level of approval is available for them. So those are the selling features. Now, apart from that, we have developed a GUI, a graphical user interface. So a user doesn't need to go through command line operation of the tool. They can just select appropriate options, click on the OK, and as shown in this video, within few seconds, you will get a complete comprehensive clinical report as a HTML file. We have also implemented few computational engineering concepts to make it faster and compatible for smaller computer systems, so that it doesn't depend on very heavy high-end computational systems all the time. Although having a better computers will be always helpful and recommended. To validate the findings of the clinome, we have analyzed 11,000 patient samples from TCGA. And what we have observed is that roughly about 10% on an average are attributable to approved therapeutics, as can be seen here. And in few of the cancer types, we can see that this percentage goes very high, as high as 70%. When we consider the approved and off-label therapeutic considerations, this percentage increases to about 18%. And when we consider ongoing clinical trials all across the globe for precision medicine, roughly about 40% of the patients are directly attributable to one or another therapeutic option. So that gives us tremendous hope in the near future. So that brings me to the final slide. We have seen how comprehensive NGS analysis right away can save a lot of time and tissue for the patients, and how it can help us get more comprehensive idea of therapeutic options. And we have also seen that how pairing this comprehensive sequencing with clinome type of computational solution can help us get the broader picture and more efficient identification of therapeutics across all the cancer types. Thank you all.
Thank you, Dr. Pratik, for giving an understanding about the clinome which we have developed. Any questions? Okay. If not, thank you, Dr. Pratik. May I call upon the next speaker, Dr. Anu Rasalam, who is a head of clinical biochemistry, specialist in precision oncology and multiomics, MVR Cancer Center and Research Institute. In spite of she was suffering from recovering from her illness, she has come across with my request. Thank you, Dr. Anu. She will be speaking on EGFR exon 20 insertion, distinct EGFR mutations in NSCLC with practical applications.
Thank you so much, ma'am. Thank you, organizers, for having me here. So what I'm trying to do is bridge the gap between the cancer biology part of EGFR exon 20 variations and the therapeutic conundrum that we see in the practical world. I have no conflicts of interest to disclose. So let's see what the molecular dynamics of EGFR is. We know that the gene lies on chromosome 7, region 1, band 1, and subband 2. The size is around 192,000 plus bases. The amino acid is of 1,210 size. There are 4 isoforms. And functionally, it's a receptor tyrosine kinase that catalyzes transfer of a gamma phosphoryl group from the ATP to tyrosine residues on the protein substrates. The receptor has almost ubiquitous expression throughout all cells of the body. Biochemically, it's a single pass type 1 membrane protein. You can see there's just one alpha helix that passes through the membrane, be it the nuclear membrane or the cell membrane or of the organelle. There are three parts to the receptor. One is the extracellular domain, the transmembrane domain, and the intracellular domain, which is the more important one and the conserved one evolutionarily. So moving on to the dimerization. When a ligand binds, ligands being molecules like EGF, TGF alpha, etc., that leads to dimerization of the receptor. It can either be a homodimer or a heterodimer. That leads to a phosphoryl group transfer from ATP to the receptor, which is the process called autophosphorylation. And that leads to an asymmetric kinase domain dimer, which helps in these phosphorylated tyrosine residues within the kinase domain will actually attract other molecules or substances like SHC, GRB2, and they in turn lead to downstream activation of the usual pathways, RAS, pictosea, all that we know, which is downstream of EGFR. And finally, that leads to cellular growth. Now we know there is a clinical enigma related to the atypical EGFR mutations. So you can see almost half of the atypical EGFR mutations are contributed by exon 20 variations. Down here, this is the TTF, time to treatment failure graph, where there's a clear demarcation and a poor OS benefit when it comes to atypical EGFR mutations, especially the exon 20. Now, why does this happen? This was a landmark paper which showed that just one insertion, the FQEA, which you all know, was the only one that had a good response rate to the early TKIs. None of the others showed a response. Why was that? That brings us to the genotype quaternary structure relationship. Here, as you can see, and we all know that more clinically relevant mutations happen in the tyrosine kinase domain. And of that, the exon 20 has more of insertions and point mutations. On a closer look, the exon 20 region codes for part of the transmembrane region and the N lobe, which is part of the intracellular domain. And that is part of the tyrosine kinase domain. And this part is important. The ATP binding cleft is actually coded by the exon 20 region. This was a really good paper last year where they sort of divided exon 20 variants into the whole of EGFR mutations into structure-based classification. So they found 4 types: classical-like, T790M-like, exon 20 loop insertions, and P-loop alpha C helix compressive. So these were based on structures of the EGFR, depending on what mutation they studied. Now, as you can see, the exon 20 loop insertion, when this happens, there are 2 types called the near loop insertion and the far loop insertions. So they respond differently to the clinical TKIs that we have. Now, why is that? Structurally, what happens is the P loop is pulled down and the C alpha helix is pulled inward. Thus, the hydrophobic core is sort of compressed inside. So these mutations in the near loop and far loop domains, they are sort of resistant to binding of the TKIs. So to start that, like with the T790M mutation, it is thought that it was because of the steric hindrance that they were resistant to the earlier TKIs, because threonine is a smaller molecule, methionine is a larger molecule, so it comes in blocks the ATP binding cleft. But now we know it's not basically the steric hindrance that's happening with these resistance or non-efficacy of first generation or second generation TKIs. It actually, these mutations causes an increase in ATP binding. So with early TKIs, the mechanism is by reversible binding. So they compete for the ATP to bind to the ATP binding pocket. Now, with these mutations, what happens is that the competition is sort of brought down by increasing the affinity for ATP. So that is why you require a covalent binding molecule, which should be an irreversible binder that should replace the ATP and completely prevent binding of ATP so that you can block the entire downstream pathway. Now, the early part, this is the one nearer to the exon 19, the FQA and LQA insertion. These two behave like the classical loop. So that is why they have a different clinical correlation, or the efficacy is different with these mutations, just these two. So what I'm trying to tell here is that, as Dr. Akhil was speaking earlier, it simply doesn't, you shouldn't just look at whether there is an EGFR mutation or whether it's just an exon 20 variation. You really have to go in depth and see what it is actually causing at the structure level. Only then you'll be able to predict the benefit of whatever TKIs you're planning to give the patient. So this is what I've just said, the exon 20. Structurally, it has the code for the C helix and the loop following the C helix. So whatever is nearer to the C helix will behave a little like the exon 19, and whatever downstream will behave differently, and they'll have a different benefit or an efficacy to the TKIs. A graphical representation. So this is what happens in a normal setting. This is the N lobe and the C lobe, which is the molecule or the part or structure that is coded in the intracellular region. This is how it looks like. In the middle, this is the ATP binding cleft. So in an inactive state, when there are no ligands, the C helix, this part, is sort of, it juts out and blocks. So the whole molecule or the whole receptor is inactive. And when there is ligand binding, the C helix is thus pulled inside. The ATP binding cleft is open, ATP can bind, phosphorylation and downstream activations can happen. What happens in an exon 20 insertion? There is an insertion here, addition of nucleotides and thereby amino acids. So the C helix gets pushed into the N lobe. Now the ATP binding cleft is open. So even without a ligand, a natural ligand, the whole receptor and the domain, tyrosine kinase domain, would be active. And this leads to constitutive activation. Moving on to the therapeutics. We know that there mobocertinib, oral mobocertinib is there approved, and the injectable amivantamab is approved based on the CRISAL study. So these are the molecules. Right now we have poziotinib, mobocertinib, the bispecific amivantamab, the HSP90 inhibitor luminescent. So HSP, the heat shock protein molecule, is actually quite necessary for the structural, to maintain the structural integrity. So if you block that, downstream signaling wouldn't happen. These are some of the emerging therapeutic molecules. The ones below, all are on more than second line, and the ones below, they have, they do show an ORR, but we are yet to see the benefit in PFS and OS. The others that we spoke of now have definite benefit. Some of the ongoing phase 3 trials, immunotherapy, VEGF inhibitor, and chemotherapy, TAC-788 versus platinum-based chemotherapy, toripalimab with chemotherapy, and amivantamab with chemotherapy versus chemotherapy alone. So these are some of the trials that we are looking forward to with respect to EGFR exon 20 variants. Having said all that, this is the reality that we have. We speak about all fancy molecular testings, reportings, and correlations, but there's still part of the world which have no access to testing at all. So I mean, my message would be that we really need to expand testing. We have to go in depth. We have to sequence all patients, be it up front or down the line. And remember that there are still patients who do not have access to any sort of testing. So we need to have a global effort to increase awareness, bring down the costs, do extensive testing, and also request companies to bring down costs. Thanks. I acknowledge most of the institutes I've been working with or affiliated with, and wouldn't be here without them. Thank you so much.
Thank you, Dr. Anu. The talk is open for the discussion. Any questions? So I would like to ask one question. How do you see exon 20 insertion now? Earlier, it was only acquired T790M mutation was important to look upon. But how do you see as an acquired resistant mutation of exon 20 insertions? Have you any experience in it, or you see only at the upfront or at the baseline exon 20 insertion?
Mostly at the baseline.
At the baseline. Okay.
Very interesting talk, Dr. Anu. Regarding this HSP90 blockade approach, which can be universal to all the EGFR resistance mechanism, I guess?
Yeah, it should
can
be.
be tried?
Theoretically, it should be. Yes, because it is well downstream and it's a very critical part of the downstream activation. So that is why we're looking forward to Luminescent trials.
Okay, great. And regarding the initial responses, duration of responses and early recurrence, what do you predict insertion of these variants actually of the exon 20 insertions? Do they have a difference in terms of response rate, which you already showed actually?
Yeah.
In terms of duration of response, they may have early responses and then they fail. Do you have some comment on that? Because there's it's not absolute that you do not see response at all.
Yeah, that would actually depend upon co-mutations as well, I'm guessing, because, and also maybe the clonal part of it. If it's a very small one, patient may benefit from other therapies, and the overall response rate would be different, because we speak of duration of response and as a holistic term.
If you were to give an option to choose among all the treatment which you have mentioned, osimertinib, mobocertinib, and all, amivantamab, which will be the best you will choose for the Indian patients?
Would depend upon the scenario that we're dealing with. One is oral, one is injectable. That's a different, that is also important. Patient needs to choose. I mean, I would actually speak with the patient first, put everything on the table, the projected PFS or whatever we're trying to get into, and also the mode of administration. And then we'll actually really sit with the patient and explain all this, and then come to a conclusion, decide which one. And also the amivantamab is a bispecific inhibitor, so we'll also look into the c-Met part of it. So it'll really depend on whatever case scenario that we're dealing with. That is.
The monoclonal antibody bispecific EGFR and c-Met. When we talk about this exon 20 insertions, which is not happening, which is happening way down in the signaling pathway, and we're just trying to block the receptor over there. Yeah. Of the two, do you think there's a role for only an anti-EGFR inhibition alone without the c-Met part? Like, we have another drug called cetuximab, and amivantamab is half cetuximab and half as c-Met. So from the molecular perspective, from the mutation, from the conformational change, blockade of what do you think is actually providing us the benefit? Is it the EGFR part or the MET part?
Both, in fact, and
more
of the EGFR.
Does MET talk to exon 20? Is that important?
Yeah, more of the EGFR, I would say.
More of the EGFR.
More of the EGFR.
So do you think there may be a chance that even cetuximab may do the same job?
Yeah, we'll have to see. I mean,
just a
we'll
thought.
have to, yeah. Yeah, that is a great question.
Well, I mean, just a comment that cetuximab would be different than for these heterodimers between the EGFR and c-Met. So, Dr. Anu, now that there are more and more emerging evidences of these exon 20 mutations in HER2 as well, right? And recently the paper kind of like describes them. So whatever you said about the EGFR exon 20, is it totally analogous to the HER2 EGFR HER2 exon 20 as well, and everything would be applicable? Or do you see any obvious or significant
No, it
differences
would be
between them?
different. Wouldn't be exactly the same. Though they are all part of the same family, there are differences. And HER2 being unique, as there is no ligand known, it's kind of an orphan receptor. The downstream conformation changes are going to be a little different. A little different. I'm talking in a nanoscale level. So overall, I'll have to check.
I mean, a recent report of phase 2 talks about the poziotinib, even for the HER2 to be like, maybe
yeah,
not.
yes,
So
that's why it depends on what conformation change that is leading to exposure of the ATP binding pocket or not. So if the pocket is open, then your reversible or the irreversible inhibitors may work to an extent. But there are finer conformational differences. That comes down to what amino acid insertions or deletions you're talking about, or what point mutations. If it's almost a similar amino acid, so something like both are polar or both are non-polar, there's not much of a difference that's going to happen there. But if one is polar and it's being replaced by a very bulky with numerous side chains, and that being non-polar, it's going to cause some differences in the hydrophobicity. These all lead to steric hindrance and structural conformation differences. At that scale, at that nanoscale, there might be differences in drug binding. So that will also affect the final downstream efficacy that we're talking about. So it will be very, very specific, even while designing clinical trials. RCTs. To be really specific, as you spoke about the STK11 and KEP, there are conflicting evidences. You really cannot say that all STK11s are going to be resistant to immunotherapy, or there might be inter-individual differences because every patient is different, every tumor is different, everybody has heterogeneity. So that's where precision oncology comes into play. Really have to tailor it down to that patient, that profile, and look at co-occurring mutations. There are mutual exclusivities that happen. So I would like to look at everything at that nanoscale level so that it will really benefit the patient rather than going about a vague game.
Thank you, Dr. Anu. I'll call upon next speaker, Dr. Ashwin Butler, who is a postdoctoral fellow at Dr. Amit Dutt's lab at Tata Memorial Center, ACTRAC, Navi Mumbai. He'll be speaking upon weekly osimertinib in lung cancer preclinical data. Welcome, Dr. Ashwin.
Thank you, organizers, for this opportunity. The topic of my presentation is weekly osimertinib in lung cancer, preclinical data. As we know, lung cancer is the most common cancer and leading to the most responsible cancer for the death. Histologically, the lung cancer categorized into small cell lung cancer and non-small cell lung cancer. Furthermore, the non-small cell lung cancer categorized into lung adenocarcinoma, squamous cell carcinoma, and large cell carcinoma. Coming to the treatment with the EGFR tyrosine kinase inhibitors across the years, in 2004, EGFR mutations are discovered in non-small cell lung cancer. In 2009, gefitinib approved for EGFR positive patients. In 2019, erlotinib and afatinib comes as a first line treatment for the EGFR positive patients. And in 2015, osimertinib is approved for the T790M positive patients. In year 2020, osimertinib is approved as an adjuvant treatment for EGFR positive patients. So osimertinib, as we all know, is an oral third line, third generation EGFR TKI uh, inhibitor and is a standard care therapy for a patient who showed T790M, L858R, and exon 90 deletion. From with this molecule, the great ADURA clinical trial done with the resected EGFR mutated non-small cell lung cancer patients. Here, the patients were randomized into 1:1 ratio, where one group is treated as a with the osimertinib as an adjuvant, while other group is treated with the placebo. This trial resulted in, and it shows that the patients with who's treated with the osimertinib shows significant disease-free survival as compared to the patient treated with the placebo. So this study concludes with the daily dosing of third generation EGFR TKI osimertinib as adjuvant treatment in resected EGFR mutation positive non-small cell lung cancer patient extends the disease-free survival. And after that, osimertinib approved for as a adjuvant treatment for a patient with early stage EGFR mutated non-small cell lung cancer patients. When we gone through some literature of pharmacokinetic values with the osimertinib, we found that the distribution of osimertinib was maintained in the brain up to 21 days. That's why, so we asked the question, can a weekly dosing of osimertinib replace daily dosing? And to assess this question, we need a preclinical, appropriate preclinical, and the Dutt laboratory established a preclinical model to characterize genomic alteration and novel therapeutics. So for lung cancer, we have developed two kind of orthotopic lung cancer mouse models. First is from tail vein, and other is the cell implantation through the intercostal into the not-skid mice. Also, we established a tongue cancer mouse model for head and neck cancer into the nude mice, orthotopic xenograft of cervical cancer in skid mice, and the breast cancer mouse model is currently underway in Bakshi mice. So, with this tail vein mouse model, we set to model the ADURA trial using this model. But we have selected a non-invasive bioluminescence imaging to detect the small number of cells which home into the lung of mice, because among the all imaging techniques, we found the bioluminescence imaging is most sensitive to detect the tumor cells. Among the other imaging modalities like ultrasound, CT scan, MRI scan, PET scan, SPECT. But to get detected in the bioluminescence imaging, first we have to tag the lung cancer cells with the luciferase gene. That's why in vitro condition we culture the luciferase plasmid with the virus plasmid, and then we generate the virus with the luciferase plasmid, and that virus particle infected to PC9, which is lung cancer cell, and when we add the luciferin with the cells, we saw the bioluminescence appear in vitro condition. Below this image shows the the actual picture of the experiment. The PC9 luciferase cells shows bioluminescence in Blackwell plate. Now coming to the tailbone mice model, it is the attractive tool to assess the homing of lung cancer cells into the lung. It is easy to perform and cells implant into the lung of mice through the tailbone within a 24 hours, and it is easy to colony formation. So using this experimental mouse model system, we can assess the homing of lung cancer cells into the lung, which can mimic the condition used in the ADURA trial. So into the establishment of orthotopic lung cancer mouse model with by intravenous injection, we have selected the skilled mice because skilled mice has impaired innate and adaptive immunity, and also it has lack of B and T cells, and also the lack of dendritic cells as well. So to start with, this skilled mice anesthetized with the isoflurane in anesthesia chamber. After that, in aseptic condition and under the continuous isoflurane inhalation, we inject the PC9 lung cancer luciferase cells through the tail vein, which will be seeded into the lungs within a couple of hours. After that, within a couple of hours, we intraperitoneal inject the D-luciferin from the firefly and subjected this mice to the bioluminescence imaging system. And this imaging system shows us the bioluminescence appear at the lungs of the mice, which depicts the presence of homing of the lung cancer cells into the mice. So with this model, we strategize the experiment for alternative TKI dosing. For that, we divided mice into the three groups. First group is for the vehicle control only, wherein we treated the mice with the PBS on PBS. In second group, where we provided erlotinib and osimertinib in daily dosing regimen from -3 day to 5, and bioluminescence imaging will perform up to day 18. In the third arm, where we have provided erlotinib and osimertinib in weekly dosing regimen in an interval of 7 days. The result of this study shows in the control arm, there is a continuous homing of PC9 luciferase cells and also increasing in the luminescence up to day 18 shows the proliferation of the cells into the lungs of mice. In the daily dosing regimen, none of the mice from the erlotinib and osimertinib group shows the proliferation or homing of cells. But interestingly, in weekly dosing regimen, erlotinib treated mice fails to prevent the homing of lung cancer cells into the mice, while in osimertinib, even with the weekly dosing regimen and even with the 2 supplement post cell implantation, it shows a similar effect as compared to the daily dosing regimen of TKIs. In summary of this study, we kept these mice up to day 30, wherein we can summarize that in daily dosing regimen, the homing of cells is prevented, and also there is no tumor formation. And in weekly dosing regimen, only osimertinib treated arm shows no tumor formation. It means the osimertinib in weekly dosing regimen can achieve the similar effect as daily dosing regimen. The most importantly, in clinical setup, osimertinib costs more than 4 lakh per month. By this, by adopting this weekly osimertinib dosing, we can reduce the cost 1/7. This is the studies published in Translational Oncology in 2021. And for this acknowledgement, I would like to thank TMC ATRAC, my guide PI, for his support and guidance. Clinical collaborator, Dr. Vanita Narona and Kumar Prabhash, and all my lab members. Thank you.
Thank you, Dr. Ashwin, for your wonderful work. Any questions? I think we can have during the lunchtime also, because due to the paucity of time, we have to. Thank you, Dr. Ashwin. Excellent. May I call upon next speaker, Dr. Asim Joshi, again happened to be PhD student from Dr. Amit Dutt lab. He will be speaking on low frequency of T790 mutation detection in lung cancer using NGS platform.
Good afternoon all. So I'll be discussing about our research work on low frequency T790M detection in lung cancer using NGS. So as we all would be aware that EGFR mutation testing is a routine practice for lung adenocarcinoma patients, and patients which have EGFR sensitizing mutations like mutations in exon 18, 19 or exon 21 are routinely treated with gefitinib and erlotinib, which are the first generation inhibitors. And we also know from a number of clinical trials carried out abroad as well as in India, in Tata Memorial Hospital, that the EGFR mutation positive patients treated with this first generation inhibitors have a significantly higher progression-free survival compared to those patients if the patient is treated with chemotherapy. However, majority of these patients, like more than 80% of the patients, they develop resistance to this first generation EGFR inhibitor treatments. Now, why do these patients resist? Is the primary reason for this is because of the secondary mutation in EGFR, which is the T790M mutation, which is known to occur in 50% of the cases. And we also are aware that for these patients who acquire T790M mutation, the standard of care treatment is osimertinib, which is the third generation inhibitor, as is also proven by a number of clinical trials. And thus, for patients who resist this first-line EGFR tyrosine kinase therapy, first-generation therapy, or the EGFR T790M mutation testing is a routine practice, and usually real-time based PCR is used for this diagnosis. Now, recently, there have been papers where they say that there is a association between the allele fraction of T790M and the osimertinib response. What they say is that low allele fraction of EGFR T790M, it is associated with a poor response to osimertinib. However, all of these studies are actually on the, like you say, the liquid biopsies, and the clinical utility of osimertinib to low allele fraction T790M in tissue biopsies is yet to be explored. Thus, we raised the question whether osimertinib can benefit patients with resistant tumors harboring low allele fraction T790M mutations. Now, to address this, what we did is we longitudinally collected biopsies from lung cancer patients who were EGFR mutation positive, and they responded to the treatment. Then they resisted this treatment and eventually showed resistance to this treatment. However, what we set a criteria that this resistant tumors, it should be negative for T790M based on real-time PCR. So this is how we collected the samples, and we performed an whole exome sequencing on it. And then we detected whether we can see if there are any low allele fraction EGFR T790M mutations that can be detected. And indeed, if you can see indeed what we observed is that in 4 out of 16 patients, the EGFR T790M mutation, which was missed by the conventional real-time PCR, was actually detected at a low allele frequency. When we checked the reads and in the IGV screenshot, we could see that there were all of these were at a very low allele fraction of 5 to 6% in 4 of 16 patients. That means 25% of the patients were actually false negative based on conventional real-time based PCR. Next, we wanted to model this in the laboratory settings, and for this, what we did is we took PC9 cells. So PC9 cells are lung cancer cells which have EGFR exon 19 deletion, and we treated it with erlotinib until we could see clones which could resist this treatment. So we termed it the PC9R cells. And if you see the drug response curve, this blue one is the PC9 and red one is the PC9R. So we could clearly see that PC9R was resistant to erlotinib. And to ensure that both of these cells are actually from the sensitive cells, we did an STR profiling, and we confirmed that PC9 and PC9R were actually identical. Next, what we did is we performed a Sanger sequencing to check the status of EGFR T790M in this PC9R cells, the resistant cells which we were developed, and we could actually see that there was no T790M. That is, based on Sanger sequencing, we did not detect T790M in the resistant cells, the PC9R cells. However, when we did an NGS on this, we could actually see that while the PC9 cells, they did not have a T790M, but PC9R cells, they had acquired T790M at a lower allele fraction of 5%. So which was actually the case when in our patient samples as well, wherein initially those which were missed by the conventional T790M detection which was missed by the conventional PCR-based techniques was actually detected by NGS. And similarly, we observed it in the cell lines. Next, we confirmed this. We validated this T790M mutation using an allele-specific PCR, wherein what happens is we design primers such that only the mutation, if the mutation is present, we see an amplification. And if you can see the PC9 cells, there was only amplification following the wild-type specific primers, and there was no amplification following mutant-specific primers. However, for PC9R cells, we could clearly see an amplification based on mutant as well as wild-type specific primers, confirming the presence of T790M in PC9R cells. Now, this T790M, we wanted to confirm what could be the biological basis for it. So there could be 2 reasons. One there is, as we all know, that there is a tumor heterogeneity which is in place. So is the T790M low allele fraction because of the tumor heterogeneity? Or is there an amplification of the wild type allele at the EGFR loci, because of which this low allele fraction is detected? So for that, what we did is we took this PC9R cells and we sorted them, and individually we grew about 20 colonies. And in those 20 colonies, we again did a allele specific PCR to confirm whether T790M is present. And actually what we observed is in all of these 20 clones, we could see that T790M was present at a low allele fraction, which was detectable only by allele specific PCR and not by Sanger sequencing. Thus, we concluded that this PC9R cells acquired EGFR T790M at a low allele fraction of 5%. Next, we went on to check whether osimertinib is actually active on this low allele fraction harboring PC9R cells. So, and we could see in vitro that this both PC9 and PC9R cells, so PC9R cells with a lower allele fraction of T790M, they were equally responsive to osimertinib in the in vitro conditions. Then what we did is we took the cells, and as was described in the earlier presentations, we tagged them with luciferase to monitor the, so that we can monitor it in the mice. And we injected these cells into orthotopically into the lungs of mice. And we followed whether this mice, even in the in vivo settings, whether this osimertinib response is seen. And we actually concluded that this is the, so before that we checked whether our model is well established, and we confirmed that we could see the clinical signs and symptoms of lung cancer in this the mice which were injected with this PC9 cells, like pleural effusion. We could see loco-regional metastasis to the other lobes of lungs, and this tumor formation was confirmed using H&E staining. And then we checked whether this PC9 and PC9R cells, we injected them into mice to check the response of the drugs on the EGFR TKIs on this mice, and we saw that in case of erlotinib, only PC9 was responsive. The tumors, obtained from the PC9 cells, and in PC9R cells, the tumors were resistant to erlotinib treatment. However, as was seen in vitro, we saw that even the in vivo tumors, they responded to osimertinib, but they were resistant to erlotinib. And in osimertinib, both PC9 and PC9R cells were equally responsive. Thus, to conclude, so we observed that 25% of the patients are actually, they are missed by the T790M status in 25% of the patients is called to be false negative by real-time PCR, and in a way they are not given osimertinib because their report is negative. And hence we again would like to put emphasis on the fact that NGS needs to be done on at least on those patients who are who are negative based on real-time PCR, to confirm whether they have this T790M at low allele fraction. And this osimertinib treatment, which is a standard treatment, it can still be applied to low allele fraction EGFR T790M patients, and thus we in a way extend the benefit of osimertinib to a larger group of patients. So I would like to thank my team, and thank you to Anuradha ma'am for inviting me. Thank you. Yes.
Sacrifice the mice eventually due to autopsy?
Yes.
So have you analyzed the T790M mutation in those outgrown tumors post osimertinib?
So post osimertinib, sir, we did not see any outgrowing tumors.
So day 56, there was a tumor in PCR9.
That was for
no, that was osimertinib day 56.
So sir, that was those are some residual cells which are getting picked up. So as such, tumor was not there. Okay. So we could not isolate the tumor. So when we sacrificed it, the lungs did not show any tumor.
Okay. Thank you.
Thank you.
Good afternoon, everyone. Thank you, Asim. Now we'll be calling Dr. Arpanadar, who will be joining online, and she'll be talking about molecular landscape of non-small cell lung cancer. Dr. Arpanadar.
All right, good morning, everyone. Thank you, Dr. Chogley and organizers for having me here today. Unfortunately, I cannot deliver this live over there in person, but I'm sure looking forward to meeting my friends and colleagues. Nevertheless, thank you for the opportunity and for giving me the task to shed light on the molecular landscape of NSCLC. So without much further ado, let's get started. So the first question, what have we, wait, my slide's not moving. Oops. Okay, you go. So what have we learned about lung cancer? So we've learned that it's possibly one of the most molecularly diverse cancers. I mean, even if you just look at the NSCLC in particular, and just look at how it's evolved. We've gone from treating NSCLC as one large homogeneous group to slowly we've moved on to categorizing it based on histological subtypes. And even from there, if we just look at the adenocarcinoma subtype, it is molecularly diverse. And so I want to draw your attention to this, greater than one oncogenic driver mutation, which constitutes around 3% of our cases. And to keep this number in mind, I'm going to revisit it in a bit. So what does the landscape look like for us in 2022? Now, this is a screenshot from the most recent NCCN guidelines, which recommends a minimum of EGFR, ALK, ROS1, KRAS, BRAF, NTRK 1, 2, 3, MET exon 14, RET, and PD-L1. It's like gone are the days when it was like at least an EGFR, ROS1, EGFR, ALK, ROS1, and PD-L1. And it's not just in the adenocarcinoma type, even in our squamous cell carcinoma. So just very quickly, what are the sample options that are available for us to do molecular testing? Tissue has always been the gold standard, no argument there. So at diagnosis, you do a biopsy. At progression, you do a prior biopsy, preferably from the new metastatic site. However, the ground reality is that while we'd like the blocks to look something like this, tissue can be an issue, and to combat tissue being an issue, liquid biopsy is a good alternative, especially in a stage 3B and greater lung cancer. You isolate the circulating tumor DNA from the bloodstream. ctDNA is the somatic DNA that is released from the cancer cell into the bloodstream, and the ctDNA is isolated, and molecular, or as we say, tumor profiling is done. And one of the key apprehensions or concerns with liquid biopsy has always been its concordance with tissue biopsy. And through the Nile slip studies, we've seen, especially in our advanced NSCLC cohort, a concordance of as high as 98%. And in addition, where I think liquid biopsy has a couple of pros versus tissue biopsy, because it's a non-invasive test, you can actually use it to, monitor treatment responses. You can monitor resistance mutations, and in addition to that, you can address that issue of tumor heterogeneity. So in the recent IASCLC consensus statement that was led by Dr. Christian Rolfo, we were reminded that there are some key differences between tissue and liquid biopsy in lung cancer. So with tissue biopsy, of course, we get the cancer diagnosis and pathology information. You get an assessment of markers like PD-L1 that are non-genomic. But of course, tissue is harder to get. It takes a slightly longer time to get results, and it's also challenging to repeat biopsies, and it's not as reflective of the tumor heterogeneity. Liquid biopsy was found to be highly concordant, fast, minimally invasive, and easy to repeat over time, and perhaps better to capture tumor heterogeneity, although unfortunately it's not always as sensitive as tissue testing. So of course, if you don't find something on liquid biopsy, it's very important to try and do a reflex on tissue biopsy. And now in the clinic, what they further advised was in treatment naive patients, there were at least 3 approaches that were recommended for liquid biopsy use. The first one is a sequential approach where tissue testing has failed. Second one is a complementary approach where you do both liquid and tissue simultaneously. And the third one is a plasma first approach, where it's clear, that we're not going to be getting, we're not going to have sufficient tissue, or surgery or biopsy is not an option, or the tumor is inaccessible, then we go ahead and we do a liquid biopsy. So, while there are multiple validated platforms and technologies that are available to call out these different biomarkers and the somatic aberrations, NGS is fast becoming the preferred platform of choice. So I'm not going to be belittling the standard of care platforms like RT-PCR, FISH, IHC, because I feel, they are the standard of care. You can't belittle them, but I do feel where NGS, with NGS, we actually get answers to the tumor biology in one sitting versus the standard of care platforms. And in addition, NGS is proving to be more cost effective, improved turnaround time, tissue preservation is there, but the key points for me is where NGS kind of has an edge over the standard of care is that you have the potential to discover more actionable targets. And remember the pie chart I showed you earlier, where 3% of advanced NSCLC cases, patients actually have multiple oncogenic driver mutations. Well, NGS called them out in one shot. So all this in turn actually helps guide and chart out a more personalized treatment for our patients. And if you just look at this in particular, this is from my clinic. This is data from my clinic, which again, over here, if you see, it proves the point of concomitant genes that are there, which has been done on NGS, and we've been able to call them out. So you've got EGFR with ALK, EGFR with MET, you've got KRAS, you've got EGFR with EGFR, and we know different variants of EGFR respond differently to different therapy. So you're giving the patient a more personalized approach. So let's use a biomarker we're very comfortable with in our clinic, like EGFR. So in an unselected population, from there you identify, let's say, an EGFR mutation, you put your patient on a TKI. After a period of time, they're going to develop a resistance, and we use imaging to confirm, it. Then we do a rebiopsy, preferably from the new metastatic site, or if rebiopsy is not an option, we do a liquid biopsy. Irrespective of sample type, we send the sample for molecular profiling. And we've identified that, as we all know, the most common resistance mutation is the T790M, accounts for 60% of our cases. However, in addition to this, we have a host of other resistance mutations. You've got your MET amplifications, you've got your PIK3CA, your HER2, and more importantly enough, your small cell transformations. Now, we also have patients who progress on osimertinib, and it obviously acquires resistance mutations. And in the AURA3 trials, we saw that 15% have C797X mutations, 19% are positive for a MET amplification. You've got HER2 amplifications, which are around 5%. And this is why next generation sequencing, and this is so important, and this also proves the point as to why NSCLC is possibly one of the most molecularly diverse cancers. So this is our algorithm. Lung cancer has always been the poster child for it. And this is where we are. These are our biomarkers and the different lines of treatment, these are the different treatment options. So let's very quickly get familiar, because I know there are a lot of talks coming where everyone's going to be specifically talking about each of these biomarkers. I'm going to very quickly run through them. So we've got NTRK1, 2, or 3. These are fusions. They're very rare. They're around 0.3% of our NSCLC cases. These are agnostic markers, and these waterfall plots for entrectinib and larotrectinib actually illustrate the majority of solid tumor cancers, lung cancer included, responded very well to TKIs. Now, the rearrangement of NTRK gene, it actually couples with the tyrosine kinase domain with a 5' fusion partner, and it generates a chimeric TRK protein ligand binding domain, essentially a fusion. Now, the most common fusion partners that we have seen in NSCLC is NTRK1 with TP53, CD74, and TPM3. NTRK3 we see with ETB6 and EML4. Now, this is a flow chart that is of testing that is recommended by ESMO, but in my very humble opinion, I think NTRK are translocations, be it 1, 2, or 3. NTRK has a low staining on IHC, whereas NTRK3 has a low staining on IHC, and NTRK1 has a low specificity and sensitivity by FISH. Thus, the preferred platform here is NGS. And in addition, it's RNA NGS because it's fusion, higher sensitivity and specificity. And the same is also being echoed in multiple international publications. RET, a biomarker that's synonymous with papillary thyroid carcinoma, but actually constitutes for 1 to 2% of our NSCLC cases. So RET gene rearrangement actually gives rise to chimeric cytosolic proteins with constitutively active RET kinase domain, in short, again, a fusion. And KIF5B is the most common fusion partner, followed by CCDC6, which is seen in NSCLC. Again, it's a fusion, so RNA NGS is your preferred platform. Therapy options, selpercatinib that we get from the Libretto 001 trials, and you've got pralsetinib, which is the blue 667 from the Arrow trials. Then we've got the MET exon 14 skipping, which is essentially a mutation that occurs at the junction of exon 13 and exon 14. And this leads to the skipping of exon 14. And what you're looking for is a product fusion of exon 13 and exon 15 that gets formed. Again, it's a fusion. So I think as a general rule, be it for ALK, ROS, MET, NTRK, anytime we're looking for a fusion, it should be RNA NGS. So when you get an NGS report, if it's negative, go back and check with your service provider, was it DNA or RNA? If it was DNA as a reflex, I would urge you to go in and do an RNA NGS. And in the cases of MET exon 14, we've got crizotinib as a treatment option from the Profile 101 trial. We've got capmetinib from the Geometry trials, and we've got tepotinib from the Vision trials. KRAS, This is the most common mutation we see in our NSCLC cases. They constitute for around 25 to 33% of cases, especially in the smoking cohort. So you're essentially looking for mutations in the GTP binding protein that connects to the receptor of the tyrosine kinase. And again, from this subtype, the G12C, it's the most common. It constitutes for around 40% of KRAS cases. And what's interesting in this subgroup are the varying TMB rates. So G13 is the highest, which is followed by G12C, and G12D has a propensity for a low TMB rate. Even the PDL1 rates over here, it's, a high, which is, a TPS score greater than 50% is G12C and G12D. And from the AMG 510 trials, we've got sotorasib as our treatment option. And again, when we're talking about treatment options, we do have PDL1, which slide I seem to have missed. We've got our clones 22C3, SV142, SV263. We've got multiple trials that have shed light and proven as to why one should do testing upfront and its importance, and that's why in the NCCN it's called out immediately. But one of the new, slightly controversial biomarkers, especially in immunotherapy, I personally feel is tumor mutation burden. So the key theory here is that every cancer's got a mutation. More the mutation, higher the neoantigen, and possibly a better immune response. So in the lab, on a minimum of a 250 gene panel, you look at the number of genetic aberrations in the exonic region. This gives you the incident idea of whether or not the tumor that you're dealing with has a high or low neoantigen load. However, here's where I think there's a slight issue with the theory. Not every mutation will cause the tumor to have a to actually have a neoantigen, that may, and the antigens, but it may also not necessarily be a neoantigen. So that's being recognized by the immune system. So I personally feel that the neoantigen may not really induce an immune response, and also the one-size-fits-all of the TMB score of greater than or equal to 10 mutations per megabase may not really be ideal. But the FDA has given a blanket approval, so I think it's still experimental. I think every solid tumor has its own different cutoffs, which we still need to identify, but push comes to shove, you've got your back up against the wall. I think Foundation Medicine has amazing data around it. Then we've now got Thermo Fisher, which again has some fantastic data. So you've got the high end and the domestic partners, which are giving Thermo Fisher's TMB, which makes it economical to our patients. And I've just got 2 more minutes and I'm done. I just very quickly wanted to just, whatever was spoken, to actually illustrate them through cases. This is a 50-year-old female NSCLC, and over here they did sequential, testing, the very quintessential EGFR by RT-PCR, ALK by FISH and ROS1 by FISH, and PDL1. Everything came negative. She was 50. She was young. So at this point, we luckily have some tumor. We sent it for NGS, and a BRAF mutation was detected. She was started on a BRAF, with a MEK inhibitor. Similarly, a 79-year-old male who was EGFR positive started on afatinib. We know he was going to progress. He eventually progressed. Rebiopsy, no mutation was detected. 79 years. Keeping his age in consideration, we sent him for a liquid biopsy. A MET exon 14 skipping mutation was detected. A VAF as low as 0.4%. Now, because liquid biopsy has a higher depth of coverage, that in turn results in higher specificity and sensitivity in calling out these mutations. It is also because of tumor heterogeneity, and this patient was immediately started on capmatinib. And my last case is of an 81-year-old female NSCLC. Tumor was insufficient, so liquid biopsy, was done. We found a ROS1 mutation. She was started on crizotinib. She progressed. Refused tissue biopsy. We again sent her for a liquid biopsy. ROS1 fusion persistent. She had acquired a ROS1 G2101A mutation. It's a known crizotinib resistance mutation. So her physician puts her on lorlatinib at this point. It was short-lived. She again progressed. A liquid biopsy was repeated. And we saw that the ROS1 was persistent, but she had lost the ROS1 2101A, but I need 1 more minute, I'm just done. But gained a ROS1 G2032R. In addition to this, we had lost the KRAS K117N, and now we had a KRAS 12D, which we know imatinib is a targeted therapy, but this could be a potential CHIP mutation. And this is something clonal, CHIP is essentially clonal hematopoiesis of indeterminate potential. So you've got to be very careful when you see TP53, KRAS, JAK2, anything with a VAF less than 0.1%. they may not always be actionable. And I think, this slide, I think best sums up this pie chart best summarizes my talk. Around 50% of our patients with advanced NSCLC have a driver mutation. And if it's not, that's targetable. And if not, there is some other FDA-approved drug or agent. There's some other clinical trials that I've highlighted here in red, which is obviously going to increase the cohort of patients that can benefit from molecular testing. And on that note, thank you very much for your patient listening.
Any questions from the audience? Nothing for now. So thank you, Dr. Arpana. We'll move on to the next session by Dr. Amit Verma, who will be talking about rare mutation interpretation based on NGS reports.
Hello, everybody. It was very freezing cold today, so I don't want to freeze during my slides. So thank you very much. Thanks to the organizers for inviting me. And I'm going to talk about few interpretations of the rare case scenarios in lung cancers, what I have come across. And I will be asking questions rather than giving answers, because this is not yet clear what is the best way to take them forward. So well, we understand the histologic and molecular heterogeneity, and we have this diagram seen in the past, you can say, presentations. So I wanted to just emphasize here that these frequency of these mutations sometimes give some clues what we are dealing with when we are not able to do a true biopsy, especially when you do a liquid biopsy. This frequency can tell that probably you are dealing with adenocarcinoma versus squamous cell carcinoma. Just to emphasize the mutation, that is the PIK3CA mutation and PTEN alteration, which are commonly seen in squamous as compared to the adenocarcinoma. So if you encounter them and biopsy is not feasible, then definitely, probably you are dealing with a squamous cell carcinoma. But that's a small bit of it. We understand the importance of the routine diagnostics, the expanded diagnostics, and the idea is to find the target, but life is not very easy. So let us try to see scenarios and see what best we can come out of with these questions. So this is a 65-year-old, a non-smoker male with non-small cell lung carcinoma, metastatic, EGFR L cross triple negative, PD-L1 and found to have a classical MET exon splice site alteration. But if you see that the patient also have other alterations like CDK4, FGFR4, MDM2 amplification. So now when we find these alterations, we are very happy that yes, I have the drug which will work for the patient very well. But response rate versus the duration of response is what we are looking at. So sometimes you may see the major clones, which are the driver clones or the driver alterations which have the dominance. You may see responses on the imaging, but it is not lasting. And the explanation can be given by other alterations. In this particular case, if I see that most of the time, whenever the patient progresses on TKI, we tend to give immunotherapy or combination of immunotherapy with chemotherapy or target therapy like bevacizumab or ramucirumab. But patient having MDM2 amplification is one of the criteria where the hyperprogression can be expected. So these information sometimes are very handy, not only to find your current treatment, but what not to give actually. So similarly, in the previous talk, we have talked about the RNA-based NGS testing for MET as well as DNA-based testing, and the importance has been already discussed, so I'm not going to repeat them again. We'll go to our second case here, which is a unique compound EGFR mutation, which is in this case, EGFR V834 and L858 are compound mutations. So we know that when you encounter these compound mutations, the expected duration of responses is not again that great. So rare alterations, again, we should look into a true prognosis of these alterations actually when we are counseling the patient. Interestingly, the patient also have this ATM truncation mutation. What does it signify? Nobody knows about it. Does it reflect that the patient may be eligible for PARP inhibitor in future? Probably yes, but a big question to discuss about in a molecular tumor board may not be upfront, maybe in the later lines of the treatment when the patient fail on target therapy, especially the EGFR TKIs. Normally in my clinic, when I see patients like this, when you have compound mutations, I tend to combine TKI with chemotherapy upfront. I do not wait knowing the fact they are going to respond or fail very soon. So, so we have seen a couple of successes, longer duration of responses when we go upfront with osimertinib with TKI with the chemotherapy in these scenarios. So another interesting scenario here we have a compound mutation of EGFR S768I and G719C. Again, compounds are a big challenge, but also we have a ALK fusion mutation. So now it is a concomitant mutation, compound and concomitant mutation together. So how to handle these scenarios? Again, a big question. Drugs which can act both on EGFR and ALK like brigatinib can be attempted, but are they truly working? So if you go and see the literature, STRN ALK fusion is again a rare mutation. It is not classical EML4 ALK. So papers have shown that alectinib has not worked for STRN ALK fusion that great. So these are rare mutations, has to be dealt in a rare way. We cannot take it generic. If you find a mutation, it does not mean that the drug is going to work. So again, you have CDK6 amplification, which is possibly a potential target, but may not be. Again, so concomitant is a well-established thing where EML4 ALK and EGFR has been reported. And in this particular paper, they have shown that the overall survival or the PFS is very, very short. So we know that we are dealing with very complex situation. I think in these scenarios, early on usage of chemotherapy may be beneficial rather than allowing the tumor cells to grow and come up with some more alterations, which may be difficult to handle later. Another interesting case, again, a chronic smoker with a concomitant mutation, which is L858R and EML-ALK fusion. So once we have the fusion report, I tend to try to see if the report also talks about the variants. In this particular variant, this is variant #5, which is very equivalent to variant 1, which may show responses to the classical crizotinib. But again, the concomitant mutation EGFR L858R will be a challenge. So we know that there are almost more than 90 fusion partners of ALK which are reported. So even for the EML4, these are the variants which we all should take care of in them, especially the variant 3 where we know crizotinib does not work. So just to give you a flavor of the possibilities what we may encounter. Another interesting case, we have a 55-year-old gentleman who progressed on gefitinib, afatinib, and chemotherapy, and who had exon deletion 19 to begin with. Did not work at all. And when we investigated why it is not working, what we came across that the patient have two resistance mechanisms. One is EGFR amplification in itself and ERBB2 amplification. So what can we do about it? Yes, this is a very interesting case, and where we gave the patient osimertinib and herceptin together, it worked, and the patient did good for 3 years actually. But if I see that this patient also have BCL2L1 today, somebody was talking about, but it's an equivocal amplification. So mutations sometimes crop up and we do not know how to handle them, but they do carry poor prognosis. Another interesting case, a 71-year-old female again had EGFR mutation, was given osimertinib, and progression within 3 months with brain metastasis. So now, most of the time, we tend to go ahead with the standard next line of therapy, that is ABCP. In this case, if you see that the patient have a PTEN alteration, which may be the you can say a de novo mutation, which is causing the osimertinib to not work actually. Similarly, if we go with the immunotherapy approaches for these patients, they may not work that well because PTEN also is a biomarker for poor response to immunotherapy for that matter. So again, these are interesting cases, and then let's talk about another interesting case. This is a 44-year-old female with EGFR exon 19 deletion, was given osimertinib, had a wonderful response, lasted for 1.5 years, progressed. A biopsy was done and showed BRAF AGK fusion actually. A BRAF mutation, which is a secondary acquired mutation, which is a known cause of resistance to EGFR. So now these kind of mutations can occur. So what are the options? Should we stop osimertinib and give BRAF-based therapy? Or should we combine them together? How to overcome these challenges is a big question. Should we just switch to chemotherapy for that matter? Maybe yes or maybe no. So, but in this case, what we just gave a single monotherapy of trametinib, a MEK inhibitor. It worked for 3 to 4 months, but again, progress, which we knew. We are not confident to combine osimertinib with so many drugs together. So this is something which we are learning how to do that, how to go about it. But interestingly, if you see the other alterations in this mutation, gives me some clues, which is a mixed clue. CDK12 truncation mutation is a good biomarker for response to immunotherapy. That is one. On the other hand, CTNNB1 is a poor prognostic biomarker for response to immunotherapy. CDKN2 and NTPA loss is a biomarker to tell that this is a cold microenvironment. There is not much of infiltration. So probably immunotherapy may not be a good choice for this patient because of mixed genomic alterations. So again, interpretation is sometimes not that simple and straightforward, and these are real case scenarios. So another interesting study, exon 19 deletion with BRAF mutation. This is a concomitant mutation in a treatment-naive patient. Patient also have EGFR amplification of more than 12 copies actually. So now what are the options we have for the patient? So again, similar situations, common challenges. So now we have a 57-year-old female, non-smoker, progressed on chemotherapy. Liquid biopsy was done. It was a squamous cell carcinoma on tissue biopsy. So we have this PIK3 alteration and KRAS alteration. So PIK3 alteration, as we know, it is matching with the expected squamous cell histology, and we were very confident. But can we really apply the best cancer therapies to this in the real case scenario? May not be. But if you see that the patient have KRAS alteration, which is activating the MAP kinase pathway, and PIK3 is activating the mTOR pathway, so you cannot target the dual pathways together. We have tried in clinical scenarios to combine trametinib and everolimus, which is very, very toxic. So practically, we don't have good answers to these scenarios. But yes, just a flavor of it. But these learnings sometimes are helpful in this scenario, like a 70-year-old female, male, non-smoker, metastasis with brain mets. Biopsy was not possible because of the poor performance status. But the patient have a similar PIK3C alteration, and it was suggestive of that we are dealing with a squamous histology rather than adenocarcinoma histology, and PD-L1 was 80%. But if you see this mutation, the patient have a lot of mutation, including the FBXW7, PIK3C amplification. But all these alterations, even if the PD-L1 is 80%, when you have PIK3C alterations, you may not see good responses to immunotherapy. That is a challenge. So if you have a biomarker, which is a good marker for response, but you have another biomarker, which is not a good marker, then it becomes a big question what to follow. Just to summarize in slide that activation of Wnt beta-catenin pathway or activation of PIK3 pathway are one of the important mechanisms for resistance. MDM2 or EGFR pathway are mechanisms for hyperprogression, and loss of function PBRM1 added to BRD7 or c-MET pathway are mechanisms for good responses to immunotherapy. So let us see another case, a very interesting real case scenario. 69-year-old female, PDL1 of 35%, was given chemotherapy first line, given chemo IO, and given chemo second line, progressed practically. and the patient have CD74 NRG1 fusion, a very rare fusion to find. So we know that the NRG1 is a ligand to HER3, and once you have the activation of HER3 mutation, practically there are not much of options to offer except chemotherapy. But in this case, we offered the patient afatinib along with the FESCO, that is trastuzumab and pertuzumab, to inhibit the combination or the heterodimerization of HER3 to HER2. That was the innovation what we did for the patient actually. Yet to see the results, but this is our foundation solid and the foundation liquid. Lot of concordance that we can see in these two cases, and it was done almost an year apart. So it reflects that this clone is not sensitive to the chemotherapy or IO therapy for whatever matter. Another interesting case. So 72-year-old female who has received 2 lines of chemotherapy have RET fusion. We are very happy to see RET fusion these days. Patient was offered pelazatinib actually, but have serious side effect. PD-L1 was 20%. So now, if we just come close and see, this patient also have ERRFIU1 truncation mutation. Many of us, even me, was not aware till I encountered this mutation actually. So this ERRF1 protein is an important protein which inhibits the pan-EGFR kinase domain actually. So EGFR1, EGFR2. So if this is altered, if this is truncated, the function is lost. So there is a constitutive activation of the EGFR pathway. Even if I use any RET inhibitor for that matter, the EGFR pathway is still active. So the option what we gave to the patient was a combination of 3, which is again a unique scenario. We gave them the option of lenvatinib because pelazatinib was quite toxic to the patient. Lenvatinib has to be relatively tolerated with the patient, along with immunotherapy and afatinib for that matter, which will have you can say inhibition. So again, a unique combination we did, yet to see the results. Last case, this is just to say that we are very happy to see when we see RET mutation actually. That's a waterfall plot, is so impressive. So this is my last case and I will stop. This is again a metastatic case with PD-L1 of 0. The patient have BRCA2 alteration. That is a somatic alteration with KEAP1 STK alteration, which we know that the patient should not or would not do good on immunotherapy. Again, MTAP loss and CDKN2A loss. So the patient was given IO and chemo. We knew that the immunotherapy was not that great. The patient had good response in the first evaluation, that is around 3 months. And on subsequent evaluation, there But if you see there's a SDHA rearrangement, which is reflecting that this loss of function is affecting the hypoxia-inducible factor, what we normally see in other syndromes. It's well proven. So this patient may benefit with VEGF therapy. Adding a PARP inhibitor makes sense because it's a somatic mutation and we are running out of options. So that was a scientific rationale. But this report tells that the MTPA loss and CDKN2A loss reflects a cold macroenvironment, and that is why we did not see very good responses in this patient with immunotherapy. So many cases to discuss, but I just shortlisted this with the timeline what was given. With that, I thank you all for your kind attention. And just to tell that the reason why we chose immunotherapy for this patient was the TMB was 23 mutation per megabase. So TMB alone is not a good biomarker. The best response rate, what we can see is in the range of 30%. And we know that the patient who have high TMB and PD-L1 low, they do not do good, but they still have STK11 and T53, you can say enrichment, which exactly was seen in this case, STK11 and T53. So again, literature is there. It's just that we have to see every case, go back and read more, which is practically not all the time feasible. But yes, interesting scenarios every time actually. Thank you very much for your kind attention.
Any questions?
That was
Ashish.
The only concern I had was that, like, for example, when you look at combining 2 treatments or 3 treatments, as a clinicians, the first question which comes in our mind is, okay, are we going to end up in some unknown toxicity, which we do not know? So how do you talk to your patient and how do you get the consent?
So it's a very interesting question. We try to see if we do not enter into an overlapping side effects scenario. If it is there, we know TKI plus TKI brings a lot of toxicity, especially the cardiotoxicity, and acute coronary syndromes are quite common, well reported. So we try not to combine TKI to TKI that common, or we try to make a regimen or a protocol which is truncated, half the dose to begin with, or we try to give a treatment-free interval and then we combine. Sometimes we go back and see literature where they have done phase 1 trial. To give you an example, there are certain trials where the people have combined crizotinib with osimertinib. So if you see the literature, you will find that they have given crizotinib post-progression osimertinib, but continued osimertinib. So sometimes we learn from the phase 1 trial experiences. Sometimes we use our common sense. Sometimes we try to use lower doses, but we explain the patient these are the possibilities. But most of the time we are using these options when we are running out of options actually. So it is not that it is upfront we are offering them to do an experimental approach. Documentation, yes.
yes.
Following points. One is that standard of care is exhausted. That is the first point. Second is that whatever is being proposed has a scientific basis, but has not been proven to be effective. And the third point is that there could be potential side effects that we do not know. That could include permanent disability and death. You should write that, permanent disability and death. And then take the consent, then it should be.
Yeah, added to that, we usually give reports from our clinic, we keep a legal disclaimer that there are no actual guidelines.
So please understand, legal disclaimer is illegal. Under the X-ray or imaging also, radiologists write not valid for medical legal purpose. It is nothing is like that.
I agree.
So you have whatever, unless you have taken the patient's consent and it includes these points, then that is the only thing that will keep you safe.
There was an alternate point that was put across on a board that every patient who undergoes a precision oncology consult should have an internal ethics committee approval as well. That is the extent where we are right now.
So,
could be so difficult to do. I'd rather not say.
So I would suggest that you document it in a multidisciplinary tumor board. Go into the ethics committee, not required.
Yes.
Then we interpret individually and then in tumor board. So many times the patients, especially like we all get emails saying, doctor, you tried everything, but my last report said you should try trametinib with bevacizumab. Shall I try that? So patients think actually that's a recommendation for them. And so what are the legal things around that? And many times, like, it's very difficult for me to tell that I may not agree or I have a different take on this, or I'm not comfortable trying this combination because I've never done it before. So.
Dr. Amit, it was a great talk. Thank you. How confident are you in giving something that is based on a phase 1 trial or a preclinical data? Because most of the time, these are the complex scenarios we see. You cannot fall back on RCTs or guidelines. I mean, that is what we see in real life. So, and most often we also get vehemently opposed in tumor boards saying that this is just preclinical data or, not phase 3, phase 4. So how would you go about that?
So again, I also face similar challenges. It is not that easily accepted. So I always wait till the patient progress on whatever is being offered actually. So again, it becomes kind of a waste option, a waste basket option. Or last resort options. So again, same challenges and difficult for me also to find the right combination. But scientifically, if we try to find answers, and we have learned over the past few years, not decade, that the combination of target therapy is going to be the next option, not the combination of chemotherapy. So how we have to learn. If we don't learn, then we cannot improvise actually. So we have to try at least. Dr. Pravesh, if you want to comment on that, thank you very much.
Ashish, one of the things which we do and which we don't realize, we do treat patients till 6th line, 7th line, 8th line in our clinic. And that we do in many tumors, including lung cancer. And really no one will have those evidences of the moment. If I go back to see that 6th line, is there some evidence for it? For drug evidence is there. What 6th line, those drug, it is not there. So there's a challenge, but we all do it. This concern is fair of this combining and giving. So the Western world, they do a good thing. And I think so, I hope we learn from that, because problem is that we learn all the bad things very fast with them. So we do have a lot of ethics committee and some very good ones, someone not so great one. So I was having discussion with Dr. Kurzok, who does in phase 1, and they said they have a blanket approval. And again, this combination, there's another challenge. So she calculated and gave a calculation that if you use all these combinations and then put into power whatever is required, so we may require more than 1 lakh studies to answer this question, if that something works or not. And we all know that is not feasible. So what she has a blanket approval from IRB for a protocol like this. So she can combine. So she has, whenever she has these multiple mutations, she combines, and she shared many of those examples, and not for specific combination. She has for any combination you try, but you keep those documentation. The problem is that this is a huge problem, but does IRB understands that? Unfortunately, no, because for them till now, they have understood there has to be trial, there has to be randomization, all the things has to be there in the protocol, the dose, the schedule, the change, the toxicity. No, here it is not known. Here only things that you documented what you're doing, but that's a solution. But problem is that solution is not available to us. So that's the moment ethics committee approves. The good thing is, in today's time, if you have academic study, then the whole sole responsibility is of ethics committee and the patient and the and the doctor. It's possible that at the end of the day, someone may prove in the court. So again, no one knows the brain of judges. We have seen all kind of ruling in the past. So it is possible. But in general, if ethics committee is involved, because that becomes a neutral party. Not only it is a neutral party, maybe in today's time for academic study, they have maybe more power than Supreme Court. The way it looks like, the way the kind of power they appropriate. So if ethics committee gets involved, then yes. The problem is that ethics committee understanding that this is a good solution. No, because as on date for them, protocol is that everything needs to be there. That's a issue there. Yeah. So, but I agree with you. Unless they say in law, unless you put with the judges, you don't know what they will give the ruling, and then you know, okay, where the law stands.
Thank you, Dr. Amit Verma, for a very interesting talk. I call upon Dr. Purush Parikh, who needs no introduction. He is a medical oncologist and hematologist. Professor and Head of Clinical Hematology, MGM's CSH, Jaipur. And previously, he was a Professor and Head of Medical Oncology, Tata Memorial Hospital. He'll be talking upon the current and emerging biomarkers, science, technology, and practicalities. Over to you.
Thanks, Anuradha. I had a chat with her. She wants me to finish in 13 minutes, current and emerging biomarker. Not possible. Okay. So I said I will pick a few of them. So all of you know more than me why biomarkers are needed. And we did a survey last year actually. And this survey included responses from 358 people, 298 from India and the rest from outside India, from the SAARC region. How can I show my slides if I can't? The full projection is not there. Can anybody from the technical team help? So 74% of the responders said that there is benefit of doing biomarkers that actually translates into improving overall survival in lung cancer. So obviously biomarkers are required. दोनों साइड से कट हो रहा है, यहाँ भी नहीं दिख रहा है, यहाँ भी नहीं दिख
रहा। थम
You copied the PDF. Can I show from here?
What is thumb?
Thank you. So one of the ones, biomarkers that I thought of talking about was MET exon 14 skipping mutations. And this is mesenchymal epithelial transition gene whose normal role is in embryogenesis and wound healing. In non-small cell, non-squamous, non-small cell lung cancer, the incidence of this is quite rare. It is 3 to 4%. But the reason why it is important is that we now have 5 drugs that are effective. And one of them, crizotinib, is actually labeled for ALK1 mutations, but here it has a very good potential to benefit patients. And you have seen lots of waterfall plots. So this shows that if you look at the best overall response rate, it's really fantastic. And except for 2 patients, everybody has responded. So this is an off-label option when you use crizotinib in here. But last year, there was approval of 2 drugs based on overall response rate of 68% for MET exon 14 mutation. So I will stop here as far as this biomarkers is concerned and go on to KRAS. And KRAS, of course, you know that has been a bedbug for a long time, and now we have drugs that are available for its action. But I would like to focus on one particular type of the Kirsten rat sarcoma proto-oncogene, which the mutations are between 25 and 33%. And it is like the immune checkpoint inhibitor with pedal on the brake or the accelerator. So normal function is to have, if it is off, it is in the GDP KRAS, and if it is on, it is in the GTP KRAS. So this is the mutation landscape for KRAS. 79,004 samples, 17.4% had KRAS mutations. And the one that I want to talk today is the KRAS G12C mutation, okay, which is seen in 1,632, that is 11.9%. The non-G12C KRAS mutations are prevalent in what we have known to have where EGFR mutation is there and response to TKI is there, that is females, current smokers, an age of more than 60 years. So as far as the biomarkers of KRAS G12C is concerned, this is glycine to cysteine amino acid substitution as codon 12, and it is most prevalent in two conditions, GI cancers and non-small cell lung cancer. Both is about 9%. Now, what is the difference between the wild type versus a mutated G12C KRAS in non-small cell lung cancer? This is data from January 2011 to 2019 from the US Clinical Genomic Database, and the comparison was between the G12C mutation versus the wild type KRAS. And the analysis was done for treatment-related characteristics, molecular profiles, real world overall survival, and progression-free overall survival real world. Now this was found. In the G12C, the rider is that 20% actually did not receive any systemic therapy. But the remaining, the most common treatment for these patients was immune checkpoint inhibitors. And if you look at the real world overall survival and progression-free survival, when given immune checkpoint inhibitors were used in the first line, the overall survival was 12 months and progression-free survival was 5 months. And the table also shows what happened in second and third line. Now this, the top part is the survival for first line therapy, but the bottom row is the survival for second line therapy. And you can clearly see that as far as overall survival is concerned, there's not much difference. So when immune checkpoint inhibitors were used, the G12C mutation did not actually change the treatment or outcome of the response. So in that case, why am I talking about this mutation and why is it an important biomarker? So that is because we now have two other drugs that specifically can target GRAS G12C mutations. And the first one, sotorasib, got FDA approval on 28 May 2021. And the other one, adagrasib, is currently being evaluated by US FDA unless somebody in the audience knows that they have taken a decision. So what is the importance is that it's a covalent inhibitor that irreversibly and selectively binds to the switch 2 pocket within the mutant KRAS, locking it in the inactive GDP bound state. And this is the waterfall plot for the best tumor response with sotorasib monotherapy in patients with G12C mutations. So again, you can see a large part of the patients are responding. Overall response rate was 37%. Median duration of response was 10 months, which is worth evaluating and worth using in our patients. Based on CodeBreak 100 study, sotorasib got the approval. Here again, I'm saying the overall response rate was 36%. The important thing for clinicians is what are the common adverse reactions which are seen in 20 or more percentage of patients. They are diarrhea, nausea, hepatotoxicity, musculoskeletal pains, fatigue, and cough. And this is the survival, progression-free survival of 6.8 months, overall survival of 10.5 months, on the basis of which this approval was given. So clearly, KRAS G12C is something that we should look for as an important biomarker that we can use. Just like in TKIs, after using for a certain while, the resistance develops. So also in this particular instance, we should expect that resistance will develop. And as can be seen on the right side, the resistance develops by another additional KRAS mutation that is seen in the patients. So this is something that we will expect in the future. So the future of KRAS medicines is we have finally approved drugs for KRAS G12C mutated non-small cell lung cancer. Mutant selective KRAS drugs targeting individual variant alleles will be like EGFR TKIs. Resistance will develop ultimately. And the pan-KRAS therapeutic targeting a broad range of KRAS would be the ultimate winners. Because if you have another KRAS mutation, maybe they will be able to circumvent that as well. Finally, for the last 2 or 3 slides, another future biomarker could be gut microbiota, because there's a strong correlation between gut microbiota and lung cancer. Common characteristics of the intestinal flora in lung cancer patients is as follows. There is decreased number of probiotics, increased number of conditional pathogenic bacterial populates, decreased abundance of genus Firmicutes, and a lower ratio of Firmicutes to bacteroides. Now, this is one hypothesis about what are the 5 pathways that correlate between gut microbiota and lung cancer. And the most important, according to me, is the lung selective trafficking, because the SFB or segmented filamentous bacteria that induce gut high 17 cells are preferentially recruited by the CLL20 positive cells which are there in the lungs. Contrary to that, this is the other view, that what actually happens is that the bacteria-induced gut high 17 cells enter circulation and promote an anti-tumor immunity. So there are 2 opposite views, but whatever is it, high 17 cells and lung cancer has some link that we need to understand better. So the take-home message is that the percentage of lung cancer patients with unknown mutations is dwindling rapidly. Novel biomarkers are establishing their prognostic and predictive value with increasing data. The MET14 exon skipping mutation is firmly entrenched. That's why I only showed you 2 slides. The KRAS mutations, fortunately, are now targetable with specific agents. The KRAS G12C data is a great example of how linked agents are getting US FDA approval. And I hope and I think that gut microbiota, which have a vital role in lung cancer, will become a new biomarker that we will see in the future. So with this, I will stop here, and thank you very much for a patient hearing.
Any questions on gut microbiota for highlighting as a future biomarker?
Yes, please. So challenges is to identify the biomarker and test for it within the feces. Correct? It has to be taken. So it could be considered as a liquid biopsy, because liquid biopsy could be any sample that is coming out of the body. When you are taking the feces, you have to make sure that it is processed immediately. And then what are you looking for? You are looking for the specific bacteria in the feces and not anything else. So you have to distinguish between the human DNA and the bacterial DNA. And S100 is something that we want to look at while you're doing that. And then the NGS sequencing for gut microbiota is well established. In fact, the gut microbiota is now in its 8th annual conference in the United States. So the technique is well established. There is a library, publicly available library of what you have to look for, and specific bacteria that are associated with a positive outcome and a negative outcome are also well established. So if you follow those norms, then it is possible to do that. Commercially, capsule that contains feces, sterile, modified feces, is also available for ingestion, so that you can normalize your gut microbiota. And in India also, Dr. Shiv Sarin has used that in patients with liver disease. That he has shown that he has improved the overall survival of terminally ill liver patients by allogenic feces ingestion using a capsule.
Thank you, sir. Sir, and one more thing, there are many other factors which will influence our gut microbiota, like our diet is there, other lifestyle, stress. So how can we come to one signature?
So that I think there is enough evidence in literature with correlation between gut microbiota and colon cancer.
Yes.
And it also distinguishes the right side versus left side colon cancer. If that data was already available for lung cancer, I would not be saying it's a future biomarker. Because the data is not available, this is going to be a future biomarker. And today I am not able to give you a perfect answer for your question.
Thank you, sir.
Thank you.
Thank you, Dr. Paddock. We move on to the last two sessions. One is we'll be taking panel discussion first, as asked by Dr. Kumar Prabhash to take it for the panel discussion. Okay, so I call upon Dr. Kumar Prabhash, who is the moderator. He will be taking the session ahead.
Thank you so much, and my apology for changing the sequence a bit, and there's some logistic reason to it. Thank you so much. And what I'll do is we'll be brief, but we'll tell you a good story. And may I request our panelist to come on the dais, please. Dr. Ravikant, he's officer in charge and head of Tata Hospital Center in Muzaffarpur. That is a place, district, which is one of the most backward district in the country, and he's officer in charge, but I'll tell you some good story about it. Dr. Moitri Basu, she's the head of NGS facility at Muzaffarpur. Moitri, please come over. Dr. Vidya Veldore, she is a senior scientist at 4 Base Care, and this is a NGS lab at Bangalore. Dr. Anuradha Chowgule, she is a consultant molecular biologist at medical oncology department at Tata Hospital. Dr. Akhil is there. Akhil is downstairs. It's okay if he's there. It's fine. Otherwise, it's okay. Dr. Amit Dutt, he's a senior scientist and PI at ACTRAC, and he deals with all the basic science work at ACTRAC. Another one, Kishore Kota. Kishore is not there. He's a medical oncologist at Muzaffarpur at Tata Hospital, and looks like he will be coming day after tomorrow because he's completing his tenure there. And Dr. Sahu,
logging through.
Oh, Kishore is online. Yes. Oh, Kishore, are you online?
Yes, sir. Yes, sir.
Hi, Kishore.
Hi, sir.
Hi, Kishore.
Hi, sir. Hi, sir. I'm able to hear you.
This phone had to do something with why I preponed the panel discussion. And Dr. Sahu is there in case he's there? No.
Yes, sir.
I'm there. I'm there.
Hi, Sahu. Good
Hi,
afternoon.
boss.
Good afternoon.
Yeah.
Good afternoon. Okay.
Kya kare, sir? I wanted to be there, but had to be online today.
Oh, no. It's our loss. But anyway, we'll have you there. I know you'll be as effective.
Yeah.
So what the topic for today panel discussion has been setting up NGS testing in remote location. So as I told you, you can't get, we do have, you can say Andaman Nicobar is there. We can have far more remote locations, but by and large, you can't have a more remote location than Muzaffarpur, and that is something 3 hours from or 4 hours from Patna. Anyone has been there? Anyone? Not here. I know the people. Anyone from audience has been there in the audience? Anyone? So please visit it. So that's the reason I chose whole team who did this job. So yes, there is a NGS facility because you have a NGS person who runs the NGS lab there. Dr. Pratik, come. Pratik needs to be there. And in fact, I wanted someone from SKMC. Pratik, ajo. So yes, so you have in charge there. It means that there is a lab there. So starting with something, and I thought the best way to say about this one is, and which is true because Dr. Ravikant is there. He's the head of that place. NGS before CBC. Am I making the right statement, Dr. Ravikantji?
Correct.
Correct? Yes. So this is a correct statement.
So you have NGS before that institute. There's a CBC happening. Don't get me wrong. Muzaffarpur doesn't have CBC. That's not true. But that institute doesn't have a CBC. That's true. The institute which has got NGS today, that doesn't have an official CBC report coming from that institute. Am I making a right statement, sir? Kuch bhi ho sakta hai. So Kishore, am I making the right statement?
Yes, sir, you are correct. NGS before CBC. This statement is absolutely correct.
Absolutely right, because Kishore is today handling that, and every a few weeks he shouts at me that CBC is not happening at that place. Why it is not happening? So yes, and not only Bihar, we are known in India. We didn't have a landline everywhere, but we had cell phone everywhere. So it does happen. It's not only has happened with it can happen with NGS, but it does happen. We had a cell phone everywhere, but we never had a landline. And this is a story from that place. Now coming to, is it needed? Kishore.
Yes, sir.
Is it needed? Do you think NGS is needed in a place like Muzaffarpur? Or we say no, it is not needed.
No, sir, it's needed. Now we are getting so many patients here, so many, same like what I got the patients in Mumbai, same patients I'm getting the same set of patients. In month, I'm getting almost 15 to, it's almost 20 lung patients, and we are getting CML patients, and the other, like what most common subset we are getting ovary patients. Most of the ovary patients we are getting, like it's almost 20 to 30 monthly ovary patients. And in all these scenarios where we can use all these molecular tests, where we can do all these things we can do with this laboratory. And mainly, if I am not wrong, this is the first center which we started NGS in Bihar. If I am not wrong, maybe I may be wrong.
So is there an NGS center in Odisha?
No, sir. No, sir.
Is there an NGS center in Jharkhand?
No, sir. No, sir. Not in Bihar. I think most of.
Is there is there in a Calcutta apart from TMC Calcutta? Oh, and apart from that place, that's a famous place where
no,
we got.
No, I think private, not in Calcutta also. No government institute or anything NGS laboratory.
So again, highlighting that you have an issue regarding it, not there in the whole area. And Kishore, who was posted there, he's our consultant there, and he thinks that it needs to be there. Anyone differs or suggests the same, that it may need to be there, or someone differs? No, kya fayda hai wahan reh ke? Yeah, go ahead, Amit.
Because anyways, the turnaround time is practically 2
So
weeks.
which place in Mumbai?
Mumbai, Tata. Why not?
No, Tata. 40,000 is the cost. Patients say, I can't take. I can't pay.
Again, the cost will be the similar.
We'll come to that. Okay. I assure you that that's what, there is a story there. Anyone thinks that other way? So Amit, hopefully, let's see, we can convert Amit that we need to have not only Muzaffarpur, other places also having. So just because you have a central lab, that doesn't mean that test is available for the patient. And how much time it takes to get the report? Anyone from the central lab? Some number? Dr. Vidya is there. Vidya, ideally, not not what we say. Next year, what will give? Today, if you send for 4 base care, 3 weeks.
Yes.
So 3 weeks. Kishore, how long the patient is willing to wait in Muzaffarpur when they come from places around surrounding areas?
Frankly speaking, no, they don't want to wait until 3 weeks. Frankly speaking, like people are.
Okay. So again, there is another issue which we don't realize. Yes, sir. Please go ahead, sir.
Very true.
So that's the reason I'm saying. When I say that in remote area it can happen, it should happen where patient wants. Not because
Sir, I just want to highlight one thing.
Go ahead.
See, when we are in Mumbai, the people are like 50% will get educated, and if we tell, as of now, there is no emergency to treat. We can wait for 3 weeks, and if I push chemotherapy within 3 weeks, you may get some side effects, and they can understand. We will wait. but what the set of patients, what we are getting in Muzaffarpur is a bit different. I am not talking about the duration of the report. What we are getting is different. What the set of patients, what we are getting in Mumbai, and what the set of patients, what we are getting in the Muzaffarpur is different. What I just want to point and what I want to highlight is, even though if I tell you will get side effects from chemotherapy, if I push within these 3 weeks, they will not understand. And they just want some treatment should be started as soon as possible. That's what it.
So, so there is an issue regarding this. You want the test to be there. Now coming to, so that we require, most likely we think that tests are required. Ravi Kanji, what was the donor's interest? So first of all, this lab was not set up by TMH. It was by donation. So someone gave the money. ये कैसे कन्विंस किया आपने? And he is the person. ये किधर को उसको कैसे कन्विंस किया? मुजफ्फरपुर में हमने लैब सेटअप करना है.
Correct. So
वो बोला पटना में नहीं है, रांची में नहीं है, कलकत्ता में नहीं है, but हमें मुजफ्फरपुर में सेटअप करना है.
So COVID did many good things for health system, and it's what great opportunity. And as a public health person, मैं पहले बता दूं कि I'm not a oncologist. I'm pure public health person, and I work in various disaster and tuberculosis and other things. Since last 2 years, I'm into data. So after the second wave of COVID, everybody is talking about gene sequencing and detecting variant. So I found one donor who was ready to support anything with gene sequencing. So I thought, then I thought, ये कोविड तो आएगा चला जाएगा, but we should place this, we should put this money, because sometimes donor also don't know what is the best way or where to invest for sustainable. They think just like I give you best example, oxygen, that PSA oxygen plant. All across India, there are so many installed, but now they are struggling to maintain and run that. So that was the main reason why I decided to put this almost 5 crore rupees we received from Doctors for You. And we decided to build this lab in SKMCH, state government, Bihar government run medical college, pathology department, because the installation is the easiest thing. The running, maintenance, and the technical support expertise is even much more important. And
so what Dr. Ravikant Saab said is very important. In India, we have more than 600 NGS machines. If you look data, and this people, the same company who puts NGS machine, they say कि इतनी requirement क्या है और data कहाँ आता है? So what he says, you have a whole lot of machine, but data coming out is far limited. So there's a concern कि भाई, so that was his concern कि भाई machine तो मैं ला दूंगा, उसके बाद क्या करोगे? So there were two angles to it. So one was someone gave the money, and then there was an NGO involved called Doctors for You, who took it up upon themselves, hey, we need to implement it. So this was the two parts of it, and then subsequently we had people from AgTrack. So we have Dr. Amit Dutt. He has all PhD students, n number of them. He does discoveries. Amit, what happened? What we got interested in Muzaffarpur to put a lab there to give a report to the people who are there almost 2,000 kilometers away from here.
So there are several aspects associated to it. I mean, besides that, there could be more of a democratization of this whole platform across in different different regions, where it would be serving the clinical needs for. The question that kind of like comes around is that this field is very much decimated with the plurality of the data. We really do not have the data from the regional centers, and encouraging more and more of the regional centers to have these centers would allow us to get an access to understand what exactly is underlining there in these regions, which otherwise is not possible at all. What percent of them, as what is started around with what exactly is the need, now that we know that there is a need to have a center in-house located at these regional centers that would cater the generation of information which would otherwise not be possible to obtain. So one of the primary interests coming from a laboratory side is that we get to understand more plural data sets besides the clinical need associated to it. And then that allows us to raise more hypotheses, generate more hypotheses, and advance the biological understanding end of the day.
So this is an advantage of interacting with your colleagues in the basic scientist lab. You can motivate them to set up a lab there, and that can not only be useful, which can be there for diagnostic. And yes, he has also in mind that he should be answering some question. Coming to TMH, Dr. Anuradha and Dr. Pratik, Muzaffarpur, ये तो दोनों होके भी आ गए. What happened? Got involved in Muzaffarpur work?
Yeah, this was very interesting to have NGS at Muzaffarpur. So it's not going to be used only for the oncology, but as Dr. Ravikantji has mentioned, it is for the antimicrobial and also for the pharmacogenomics. So it's going to be a multivariate utilization of NGS. And the COVID has taught us to be online, and we could, me and Pratik all the time on the group, we used to have a weekly meeting, and we could design and develop the NGS lab over there, and also for the instruments which has to be procured. So finally, when everything was done, me and Pratik went over there for the installation and to handle all the other logistics things.
So Pratik, there's a lot of bioinformatics, very sophisticated ones. Pratik, Muzaffarpur mein kya karne wale ho?
So sir, it's not only about bioinformatics, but frankly speaking, all kind of resources we had to arrange from the scratch. The installation civil engineers are not aware what kind of quality is required for NGS lab. So when we say NGS, it's not only the machine, the whole infrastructure to support the sensitive machine and to run it in a diagnostic accuracy level requires a lot of other things, and we worked out each solution from scratch, and a part of that is also bioinformatics solution. So thankfully we had done a lot of development for oncology along with Amit sir's guidance. So we are implementing all the solutions at Muzaffarpur right away, and we hope that in further future challenges we'll be able to cater in the similar way, or maybe even do better.
So thank you. So again, you have another group which got involved, which was useful to have the lab there. Next, you have a private player, 4 bases. Dr. Vidya, how come 4 bases got involved? उनके लिए तो कंपटीशन हो गया, बोला डॉक्टर कुमार एक तो उधर से बना दिया आप लोगों ने, अभी तो उधर सैंपल भी नहीं आएगा.
So
this is on a lighter vein. They have been very nice, yeah, base plan. So what motivated?
So as a laboratory, not like any other traditional commercial approach, we do have an interest of spreading the awareness of precision oncology and trying to bring in cost-effective NGS panels, pre-designed, validated in-house, and then translate the technology, training, analysis, everything to the society and make it available to the poorest of the poor. Because today, take gefitinib, erlotinib, or imatinib, Novartis and other companies, they are giving free drugs in many places. So if molecular testing can be made very, very cost effective to many places, particularly NGS based approach. We did have an era about 6-7 years ago where real-time PCRs were coming out so cheap. That is how I think Dr. Anuradha ma'am and others in TMH could establish EGFR testing for poorest of the poor without much problem. Now is the era where we need to provide combined molecular testing of multi-gene panels to the poor. And I think we as scientists should do something. And for base care had a similar vision, like a government setting like TMH to give it back to the society. And I think that's where we could contribute, giving small panels, which can be as which could reach to the poor. Some could pay, maybe some could go with philanthropic approach, whatever way. At least try to make it cost effective.
So not only sharing panel, they also got the manpower trained. So that's
Yes,
acknowledgement from
yes, training.
our side. So next is the most important thing, and that is only Amit and Moitri can say. Moitri, she's from Calcutta. So think about a manpower getting to run an NGS lab there. We have a nightmare getting a medical oncologist there, which is far bigger in number than the someone doing NGS. You don't get a good NGS person in Mumbai, and not only that, she changed track and changed many things to get trained. But first of all, what convinced you? What Amit did?
Yes, actually, this is quite surprising to me that somehow I got connected to Amit sir. And there was just 30 minutes of discussion over phone where he explained about this upcoming facility and also how much I can learn from this facility. And secondly, I used NGS in my PhD and postdoc time, but not hands-on. So in that case, even sir convinced me that I will be getting enter training and again a scope of learning many new things. So just because of that, I relocated from Kolkata with many other opportunities, my home, my parents, and just to have the scope to learn, I relocated to Muzaffarpur. And yes, indeed, I am really grateful to Amit sir, not only that, Dr. Ravikant sir, ma'am, Pratik, and everyone. Because of them, I now, I can say that from 0 to now, I am little bit, I can self-assess that I am 5 out of 10 regarding the knowledge of lab setting, these different mutation types, different targeted therapies that can be applied. And I hope with them, I can be more, I can learn more and be able to establish this facility and run this facility with success.
Absolutely. Thank you, Moitri. In fact, we're really thankful to her and thankful to Amit. So now we know whom to catch to convince people. So that we have realized after that. So we have two more people. Akhil, NGS lab at Varanasi, required, not required? Definitely required.
Without that, we are stalled. It is a lifesaver and we need it at any cost. We need.
So do you struggle today?
Yes, sir. They are struggling a lot. Troubling sending the samples to any institute, even if it is 1 kilometer, 2 kilometer outside your own institute, it is a challenge. You need to manage the logistic. You need to manage whether the tissue is transported properly, whether there are any efficiency is maintained, patient identification is not missed. There are a lot of issues.
And then the WhatsApp messages.
Yeah, there are so many messages. You are in that group where we try to push so that everything is on time.
Oh, good, good. So we heard from another relatively not so peripheral center, not like Muzaffarpur. Varanasi is far better. If Varanasi to आजकल तो hep place है. But will be. So coming to Dr. Sahu. Dr. Sahu, after listening to all this, do you think it's good to have a lab there? And we need to have lab at many more places, which is effective and running and gives the report. I have not forgotten the cost. I'll come to that cost part.
No, definitely. A lab in-house is nothing. You cannot have a better thing to work with. But my 2-3 points is that what I get out of this story, yes, it's a lovely thing to have these labs in the setup in the remote areas. I have 2-3 issues which I'll put it forward very, very clearly. I don't think NGS is a lifesaver to me. I would not put it in that category. And secondly, if I put this in like a place like Muzaffarpur, where Kishore told that it's more of the poor people, I think most of them would be under some government schemes. So I have 2 or 3 questions, and very clearly first to the lab questions, which I should, because I tried it in Bhopal, it did not feel cost effective to me. First, what patient load do you require to make a thing profitable? It's okay, someone gave a money, but the money ultimately has to be used in a profitable way. Otherwise, the sustenance is not done. Number 2, I want to Kishore, how many of these patients did it? Leave CML. CML is a different thing. In the lung cancer or solid tumors, did you ever change therapy because government schemes do not allow anything beyond a gefitinib in the lung cancer? I get crizotinib for BPL free. So does it make a change? Practicing Bhopal, which does not have NGS, MP doesn't have NGS, it has not hampered my way of treating patients. If the patient is affordable, 2 to 3 weeks would not matter. If I'm very sure of a EGFR positive report, very likely patient profile to be EGFR positive, IHC is good enough. I quickly call up a lab. They do it in 3-4 days. So it's a good thing. To have lab is a lovely thing. Nothing going against that. But in a practical way, do we need lab at every district place like a NGS? My point is NGS. Second is, what patient load should it make it profitable? Someone gave a donation does not mean that we do not utilize the money in the better way. Third thing, how many of these patients Kishore could change treatments and patients could afford treatment? These are 3 questions that would, then the whole thing comes in context.
Can I take that question? No, Kishore, I'll take that question. Is that okay? Yeah. So,
Yes, sir. Yes.
Dr. Shahu has absolutely valid questions. I know that when you have this lab in these places, have you thought about these things? Yes, we did. We did think about these things. So, first part is that the setup makes a difference. So, with the way I will think, or Akhil will think, and the way Dr. Sahu will think, or Bhavesh will think, will be a bit different. Because what we do, I give you example, for ALK inhibitors, we arrange 70 to 80% ALK inhibitor for patient on our own. They are not able to afford it. And we take that responsibility to do it. Someone can argue it is sustainable. I don't know, because we keep begging every few months to someone. We do on daily basis. Yesterday, that's the reason, if people who were there yesterday might have seen, there was a whole, for social worker, there was a separate meeting there. And that's what we do. We talk to our social worker on a regular basis. Hey, where can we get some fund from? So there is a way of trying to get that fund raising mechanism so that they are able to get the treatment. Now, if are able to get the treatment, now where is the test? Now we need the test to be there. And for that, second part is that, now what's the cost of the test? So only the caveat to the whole story is the report we have not given to the patient. And I was coming to the last, but as the Dr. Sahu pointed out, so I need to concede that. Hopefully in 2 weeks, the report will be there in the hand of the patient. That we have not started as yet. But having said that, let's take a step back, that how it will benefit the patient. The way it benefits, for gefitinib also you require those treatment to be there. If I want to, they have ethics committee. Just now they got 4 or 5 clinical trials approved, partnering with SKMCH. Now, how that patient will get those access? So there is an issue regarding that. There's a vicious cycle. If you don't have one doesn't come. But if you make one, I too concede to Dr. Sahu that you have to see that other things are also in place. So if I'm having NGS, I need to see that patient gets the drug. Do we do in TMH? We do it. Everyone? Not everyone. Majority? Yes. Do we see? Yes, Akhil wanted to say something.
So, sir, another way is to have a trial related to that. For example, TMH Varanasi is now having capmatinib phase 4 trial. We are going to have TDX trial. So, it is a way to ensure that at least one trial is available in all the concerned centers, so that the patients can be referred in the institutions. For example, if you are able to test for MET exon 14 skipping, and is it feasible in the first line, you can send the patient to a center where the trial is available. So it becomes easy. And now I can clearly see the number of clinical trials in India are increasing, and the pharma industry is clearly knowing that if they don't do the trials in our country, we are not going to accept that. So this is a phase shift which we have seen in the last 1 or 2 years.
In fact, I'll put it other way around a bit. Not necessarily pharma is doing as much trial as they do in Western world. If they are doing less, we have a responsibility. Are we making it conducive for them? More often than not, they get frustrated with our system and goes away. So are we making it conducive? How do we make conducive? Because we have 1.4 billion, but the moment they calculate the number which really takes treatment and are eligible for studies, you suddenly realize there's a whole lot of people who are not eligible because test is not there, fitness is not there, facility is not there. So you do have those issues there. But I do concede to Dr. Sahu that yes, if you're putting a machine like this, you should have thought about it. And yes, that's why I'm saying we did think about it.
Yes.
Dr. Ravi.
Yeah. So can I add to
Yes,
Dr.
please,
Sahu?
please.
So what Dr. Sahu has said exactly जो मेरे mind में था before setting up this thing. ये it should not be like white elephant कि आ गया और फिर कुछ काम का नहीं है या चलाना मुझे. So I was listening to Dr. Amit Verma that case, and then Purvesh Parikh sir also. So these tumor cells are also behaving like microbes, bacteria. I relate it with the tuberculosis, MDR. So there is a huge problem of drug resistant coming. In fact, do you know after the COVID, the two major global challenge, the one is of course climate change, and second is antimicrobial resistant. There is a prediction that by 2050, more than $100 trillion will be lost just because of antimicrobial resistant. Your talk was very interesting. The way, in fact, you have given one example where within 3 months, patient became resistant to the thing. So, and you said 6 lines, 7 lines. So, without NGS, we are not able to detect those mutations and start the correct line of treatment. Similarly, in tuberculosis and other, and tuberculosis is a huge problem in India. We use that gene expert machine. You must have heard that. Gene expert क्या बताता है? Just to rifampicin resistant है or not, INH, the TrueNet भी आया. But if you do the NGS of these TB mycobacteria, you will find 14 the antibiotic resistant pattern in just one click, and it's always better to start with if the antibiotic you know already these are resistant, you will start the drug which is sensitive to it. So this machine अभी जो load है, hardly once or twice we run actual the machine. 28 days वो machine तो वैसे ही पड़ा है. So we can use the same machine for doing gene sequencing for tuberculosis. The load is high. Government is not able to purchase that CBNet cartridge. So my target is to not focus just on the tumor sequencing, but antimicrobial resistant sequencing, doing research work. And my target is to bring this cost less than 10,000 rupees per test, maybe around 5,000. That is my target. I don't know कितना achieve होगा या क्या, but I'm very sure the way things are moving. अगर पहले देखे तब तो ये भी possible नहीं था. Human genome
Dr.
project.
Ravikant, he has put a target, and I'll be commenting about the cost in the last. Amit, you had some comment and you'll summarize.
To address to the questions that what Dr. Sahu had just raised, those are very pertinent and relevant questions that anyone and everyone would raise and ask to themselves. But then I see the biggest problem in these kind of initiatives is the overcoming the mental block. So the dollar value for overcoming the mental block is way too far more than the cost effectiveness or the affordability, because the cost effectiveness and affordability can be those are kind of an academic problem that can be dealt with novel approaches as well as with solutions, as what Dr. Ravikant just mentioned about, by ensuring that the machine is uptime by answering questions other than associated with oncology there as well. So I see those as an academic questions, which definitely need to be, but that can be addressed at a later point of a time. First of all, coming over the mental block that yes, we can. Yes, it's possible to be done at a center, and yes, the people around over there can be benefited. Whether how the drugs would reach up to them, that's a second question, and that can be, as what Kumar has already mentioned, that once we have the question in hand that these patients would qualify for certain treatment, then the answer we would have to explore in a subsequent way that what would be the possible ways to get those treatment to them. But unless we really have this data set and unless we really prepare ourselves to come out of this mental block that this cannot be done at a remote center, there would be no step moving further.
So, as I said, I will tell you the cost last in the end. So first, this was possible only and only because all the names, all the party I said. It would not have been possible. You had to have those some NGOs giving money, some NGOs executing, the TMH involved, ACTRAC involved, 4-base care involved, getting the right person. I forget to mention SKMCH, what he mentioned, giving a space there, because we don't have there's no building of TMH. So
in fact, now I have convinced Health Minister and Health Secretary of Bihar to fix some around 1 crore rupees just to purchase the panel for doing this testing through this lab.
So there are ways and means.
Government can support.
Government, the money which is going waste, it can be used for someone's treatment. So these were all people who were involved, and that's the reason it happened. And so again, thanking everybody. Coming back to cost, yes, today the cost will be 20,000 rupees per sample for around 52 gene panel. But plan is that shortly will with the cost will be around 10,000 rupees for 52 or 53 gene panel. That should happen shortly, maybe in a month or something like that. So yes, decent. Do you say 10,000 is cheap? No, I'm not saying that. As Dr. Ravikantji said, absolutely. Can we make it better? I do agree. It is possible to do it. Again, a struggle will be there. Let's see, the team remains and the team gives more solution. But absolutely, I enjoyed the being part of the whole effort by people around, and everyone putting various ways and means. All those meetings happening. They have gone through for 6 months, almost every week. Wednesday, which is every week Wednesday. This is what has led to this, and apart from training. Who wanted to say something? Dr. Sahu, please go ahead.
No, no. See, it's always good, Kumar boss, to have these things. And as an oncologist, I would appreciate these things. I just feel, because I have been somehow of a semi-administrative position, maybe in a smaller hospital, I always feel that that money which comes, let's say if it would have been in Patna, would the logistic would have been much better, because the transport of the sample would have been few hours, and you would have more samples reaching that place. That is the only moot point which I had, because that is the only thing. Otherwise, excellent.
Can I take the question? So I totally agree with Dr. Sahu that when we see many logistics, the answer looks different. But I'll give you one example for the same. If we have these kind of all things available, sure, we would have wanted to do in Patna or maybe Calcutta, which would have been because Patna we don't have a center, so there was no way to put it there. But I'll give you an example. Do we require people to come to Mumbai to get treatment at TMH? Shouldn't have had all centers, every state government having a wonderful cancer center. But what do we do today? If you don't have it, is it a good solution to make a good center in TMH? And you know that in ACTRAC we are adding some 600 or 700 odd beds, and Hopkins here we are adding 600 bed. Do we require to do that? Ideally, no. Every state should have had a wonderful centers, and there was no need for patient to come to TMH Mumbai. But in the meantime, if it is not happening, is this a decent solution?
Sure. No, I'm nothing taking away from that. It's just a matter of a panel. That's it.
Justifying it to you, Sahu. That's all.
Yeah.
Sahu is a dear friend, so we. And best part about Dr. Sahu is that he will give a free and frank opinion. That's very nice about it.
Thank you.
Yes, last word, ma'am.
Yeah. In the next, once we get the good experience out of learning from this kind of establishing a laboratory in a rural area, the next bottleneck is the white elephant. We should involve a technology player and say, as we increase the awareness and bring in more testing, you should bring down your reagent cost and your instrument cost so that you can support the society.
Yes.
Totally agree. So idea is that once you start something, have you looked around? There are 10 more things, work on it, and then you realize, oh, everyone benefits. But I totally agree with Dr. Sahu when he said this is not the solution. This is one solution where you have many things around it. Totally agree. And again, thank you so much. The whole team. Thank you. Absolutely proud of what we could do together. Thank you so much. Yeah. Go ahead. No, don't have to.
So I'm really impressed, first of all. Ravikant looks like to me Niti Aayog CEO. So
he struggles.
So with a vision you can achieve. So you have to have a vision. So you have not bought the NGS only for lung.
Yes.
It is NGS for all of the diseases. Then you can justify it. I think that is the aim, what we have achieved. Not necessarily it has to be the common disease and the rare scenarios also. And rightly said that it can open so many things, the trials, the research, and everybody will benefit with that platform, irrespective. And it is going to be an example for other states to follow. This is more important.
Yeah, if we don't use it, it remains white elephant. We know that we have done a disservice. Yes, ma'am, last comment.
Yes, this team really requires a standing ovation, in fact.
I totally agree.
This, in the Indian
totally
setting, to do something like this, to
Oh.
pull this off, with rightly as Dr. Amit said, the mental block is so huge. Raising awareness, whenever we talk about NGS and sequencing, it's a big no from everywhere. So in that scenario, doing something like this and trying to pull off, it's a huge deal, big one.
Also, I think it's going to change perception as you said, the price will come down if the reagents now are made in India.
And also, it's not a rocket science. Perception will be like, oh, people can do it.
Show that we can do it in Mozambique, so that we can do it anywhere in India. And so there is a market for the Indian startups to work on.
So that was the, in fact, the private player who worked on it and who helped us out is a startup. And it has happened like this. So Pankaj, me and you were there, I think so. That was discussion. अरे यार NGS नहीं है इस एरिया में, ऐसे हो सकता है क्या? मैं बोला देखो है तो सही लोग, अब पता नहीं होगा कि नहीं. And then you realize, oh, okay, people will start to keep joining, and somehow realize solution kept coming. And Ravi Kanji is again he keeps getting solution from somewhere or other.
Hi sir.
Go ahead.
Hello. Okay. So first of all, I would like to congratulate. When I saw that news on the group that Muzaffarpur has a NGS, that come as a shock as well as a very, very happiness to me that we are starting a new service there. Just one question about the mental block only. So when we are doing RT-PCR or we are sending for IRC, we are not taking into consider the cost of that. If we do a RT-PCR even in a C category at around 7,000, we do IRC cost around 3,000 to 10,000. We are already spending for that thing, but we are not ready to accept that we are getting more information at a slightly higher cost. And that's what I agree. It's a mental block only. And if we go with that, there are a lot of indications and a lot of implications which can come when we have a lot of data available, and we can make it use in various ways to justify the cost also.
In fact, I'll add to that, Alok. Sir can comment and then I'll add to that. So in fact, the cost comes down. If you take EGFR, ALK, ROS, MET, BRAF, keep adding, and then you are able to give the test at 20,000 rupees, which today also I consider it is costly. That's what the team has been like, nahi, isko aur kam karna hai. Let's see what happens finally. If we are able to do 10, then I think so we have really done a good service, and some work has happened, and the same team has been working with each other for the same, and I hope it happens. So if you add it, keep adding EGFR 4-5,000, ALK fish karoge 10,000, ROS fish karoge, ALK लेते हैं IHC 4,000, ROS fish karoge 10,000, MET आपको MET which way you want to do. I leave it to PCR करोगे तब भी 6-7 हजार, क्योंकि that MET PCR is also a bit of a problem. Keep adding, and then you realize we did the costing. So it was absolutely rightly asked by Dr. Sahu. Did you do the background? No, we did that. Yeah. So you were right in saying that sometimes we don't understand that technology may not only add cost, many times it brings down the cost. Yeah. Yes, sir. Yes, sir.
So just as how cost is being brought down, I just wanted to add our experience at Mahatma Gandhi Medical College in Jaipur. Today, all the genetic changes in acute myeloid leukemia, we are able to do the test and provide in 2,400 to our patients there. So really, what you're doing is going to be a great service to the nation. And though there are so many people who have played a vital role, there has to be one person on the ground to execute the whole thing. And I think we must congratulate Ravikant for doing that in such a fantastic job. I know he has done the same thing in different fields. I know him for many, many years. And this is another great achievement and a feather in his
hand. I'll tell you, two people, जब in discussion हुई, अरे मुजफ्फरपुर जाओगे क्या? And it was best part. They said, हाँ जाएंगे. And that to leaving a lab in Mumbai. Absolutely. Thank you so much. I agree. I thank the audience. Huh? Yes, and she's going to again second time. Thank you. Thank you so much. Thank you so much.
Thank you.
Hi. So, so we had an excellent discussion, and actually I had. So it's lunchtime and we have to vacate this room because there's another workshop at 3. Yeah. No, so actually I had planned this only with the mind that we'll have trainees and residents. So I kept it very basic, like as a clinician. So we can just discuss one question, or we can even do it in the next meeting. I have no problem with that. Yeah. Okay. So let me call my panelist, Dr. Maushami, Dr. Bhavesh, Dr. Prashant, Dr. Amit, and Dr. Pratik. Okay, Dr. Pratik has to go for another meeting. That's okay. Can you project the slides? Yeah, I can see on my okay. So yes, so I'm going to keep it very basic, like as I'm not a molecular pathologist, I'm just a clinician. So which we are better off talking to patients about what is how they are likely to behave than how the NGS machine is likely to behave, and how the tumor genomics changes. This is just a busy figure just to show that, I mean, just about maybe 10 to 15 years ago, when I went for interview in Tata, they asked me, would you care if the patient had squamous carcinoma or adenocarcinoma? Would you treat differently? I was thinking, no, I would give paclitaxel to both. So why are they asking me this question? From that time to now, just looking at molecularly targeted therapy alone, we get confused. Like so many drugs, so many trials. How do we position them? How is this player better than the other? What mutations would play a role? And it's getting impossible for clinicians actually to follow up this information. And this is where we need I mean, ideally a molecular tumor board at every clinic, which again is like, here we're talking about one NGS for the entire Eastern India, and then I'm hoping for a molecular tumor board in every institution, which is so very difficult. So I just took some of these simple cases. Some slides are from the ASCO meeting, but just to highlight a usual run-of-the-mill patient who. She's a lady who had a persistent cough. Obviously, you can see there is a lesion somewhere in the bronchus and there is a nodule in the lung. So in this situation, many times when we do a biopsy, sometimes the report may just say only carcinoma, poorly differentiated carcinoma. Sometimes the tissue is limited. So the question we have in our mind as clinicians is, or maybe when we send you the sample, do you really want to know what kind of carcinoma is the pathologist calling it? What if it's a small cell? What if it's a squamous? What if it's mucoepidermoid? Does that change the way you?
Yes. As a geneticist and also a practice head, primary diagnosis is very important, and especially based on whatever the histology and the CT and all results. This makes us more specific and a targeted approach whenever we recommend or map a particular NGS one.
So
two questions I ask
if we have
is
squamous carcinoma or small cell?
Yeah.
Do you still want us to do the NGS on that? Bhavesh,
such
what
a
do you think?
molecular characterization is not required. So a broad classification of saying like carcinoma or adenocarcinoma will help us to do the variant identification and the interpretation level and all. Because then it becomes easier for the clinicians or the medical oncologists to understand the report better, because at the end of the day, the clinical benefit of the report is very important for us and all.
So Bhavish, do you send NGS even for your small cell or anything which is non-adeno, or you only send for adeno?
So usually we do it for adeno for all of them. Squamous, we try to do it for all of them. Small cell usually I'll not send.
Okay. So this is actually a report I just got last week. It is not, doesn't belong to the PET CT what I showed you, but it's a 71-year-old lady, frail lady, has been having an endobronchial tumor, which is look, the history is very indolent, going slowly, just being managed with the biopsy was some carcinoma, probably mucoepidermoid. So the diagnosis was like a salivary gland tumor, and she kept having endobronchial ablation, RFA. Finally, she came to a point where she's progressing and now she needs systemic therapy. And then the oncologist doesn't want to give her chemotherapy. So I said, okay, let's just do the NGS and see. And NGS reports EGFR exon 19 deletion. So, and then when I looked at the VAF, it is 1%. So, I know Dr. Ashutosh.
Can I intervene? Dr. Ashish, can you hear me?
Yes, hi, yeah, madam.
Hi.
Dr. Maushmi, no. Welcome,
Yeah.
Dr. Maushmi. I can't see you, but we all can hear you.
Okay, good. So, regarding your first question about the small cell carcinoma, so we are doing EGFR, like the routine testing in case it is an unconventional small cell, a non-smoker kind of thing. So these patients are, and we have found EGFR and ALK or other mutations also in these patients. So
Thank you, Dr. Mash. So as a clinician, what I want to know is like, what if you find, I mean, even though it's rare, but what if you find a common mutation like an exon 19 deletion in a histology where you don't expect it to find? So what is the implication of that, Dr. Amit? If you find a very common, well-established mutation, what is there in adenocarcinoma in some other histology, as clinicians, would you advise us to act on it, or when you look up whether the mutation is significant or not on maybe your ClinVar or in your database, does the database wants you to put in what was the histology before you go into the molecule?
No, I mean with the changing paradigm and with the changing paradigm and with the times, it's more based on the molecular alterations.
That tumor agnostic. So like we have BRAF, anywhere is a BRAF.
Not all the, there are different kind of like alterations as what is said, even emerging evidences suggest that also for the BRAF V600E, there are other different kind of like fusion events in or where they are completely tissue agnostic. However, context do play a major role. Context and many of these responses are context dependent and context restricted. But where are we talking about? We are talking about a setting where there is no alternative treatment or an option which is available. And in case there is nothing and no.
No, but sometimes it's not like that. Like for example, this lady, she's almost treatment naive. We can do anything for her. Like we could even give her metronome.
So this is a tissue biopsy or this is a liquid biopsy?
It's a tissue from that. Okay.
I have another question. So she's been labeled as mucoepidermoid. So wasn't any IHC or anything done on her? Like,
yeah, so I think I've not put up that report, but this patient behaved like a mucoepidermoid in the sense she had a the biopsy was scanty because it was and then there were some IHCs. I'm sorry, I don't have it here, but so even my question is, so what we're suggesting is, should we actually even go back and ask the pathologist, hey, is it actually mucoepidermoid? Does the presence of this exon 19 deletion makes it adenocarcinoma? Are we right thinking that way?
I think this could have been sorted. If I think there may be the deficiency of tissue that might have not led to IHC, but usually when the diagnosis is made, this thing is sorted. At least a minimum IHC of CTF1 or P40 or P63 is done. So that is sorted. And usually we don't have such a differential of mucoepidermoid versus a lung adenocarcinoma. That's the usual thing.
Sure.
Because the recent findings is some of the characterization before the start of the treatment, like how rightly you said, tumor board. Once the results come, then the proper discussion involving the lab will be a right approach in order to take this. Because even if there is a at that interpretation level, we might ask the what are the other tests done also, because that makes us in terms of the diagnostic accuracy from the NGS side, and also if we are using any other complementary tests and all. Correct.
So one thing that I wanted to just point out is like there is also important to have like the technical soundness of the data and the interpretation of it. What we are trying to do over here is like we're trying to set aside something here, because it is in the first line, something which is evidence based, and setting aside the evidence based and targeting, harping on to something which is for which there is absolutely no evidence as such existing. So here in this case, looking at the technical aspect of it, that here the VAF, that is the variant allele frequency, is 1%. 1% in a disease where it is not approved. This is more on the borderline case, more on a case where this likely could as well be a false positive, given that the VAF is so low, as what Dr. Mehta said, that in their case, they wouldn't even report, which is something which is below than 5% of a variant allele frequency.
Yeah.
So here it has been reported. So just because it has been reported, it is more of the something of deliberation at the tumor molecular board. Just because the mutation is present, that does not mean that to change the standard line of treatment and to jump on to the
Yeah. So that again brings, this is a common scenario. So, but then on the other hand, this report was and the molecular pathology. So Anuradha ma'am, I'm sure a lot of these reports come to you to Tata for discussion. So what's the best way to go about it? I mean, do you ask them to send the file to you, or?
Yes, as Amit rightly pointed out, with this low VAF, there all the cases have been discussed in the molecular tumor board, and the collective decision has been taken. So nowadays that has really helped us for the treatment decision.
So Bhavesh, finally, are you going to give TKI or chemotherapy?
So I think if we have something with the report, very difficult to convince patient that I'm not going to give anything. So I would actually try to give some targeted therapy in clinic.
Right.
If I have some target, I'll try to attack it.
Right. Okay. So that
Can I
I
intervene?
wouldn't completely kill it. I wouldn't completely, I mean, this should be there, I mean, with the information, but keep this in the mind that this could be the second line, or this could be at later on with time, this variant allele frequency may go up. And perhaps there the response rate as well, a concomitant response rate could as well kind of like go up. So,
yes.
I feel I would like to repeat the test, because even if it is there is something wrong with the test, because 1% I have never seen, I don't accept it. So I think just repeat the test. Don't trust it.
I mean, I knew it will create a lot of controversies, so that's why I'm.
And that's why you kept the case.
Yeah. So I think in such case, we have to review the pathology. So first is a TTF1. If TTF1 is positive in this case, this is straight away adenocarcinoma. You rule out a salivary gland type of tumor. And another thing is tumor percentage. If it is a very tiny, I mean, very less tumor percentage, they have written more than 10%. But if we know, like if it is 80-90% tumor and then you have a 1% VAF, then maybe you can disregard it. But if to start with bronchial biopsies, usually you have very scanty tissue. In that, even if 10 to 15% tumor tissue and 1% VAF is, if no other tumor, I mean, alternative option, TKI may be considered, is what I feel.
Dr. Amit also had a point.
Do a liquid biopsy. Okay, if you can't repeat the tissue biopsy, I would suggest test it again, confirm it. I am not sure. 1%, even if the tumor is less, I don't think it will come.
So I missed it. It's a metastatic disease.
No, it's not metastatic, but it's
Then
unresectable.
what is the question? Why we want?
The lady is frail and she wanted to avoid systemic therapy.
Then
She,
just try TKI and see the response. What's the
right.
harm?
So
We
that's
have a
like that's
clinical
a
scenario,
clinician's way
actually.
of doing it. So
Yeah.
sometimes we even do that even without all these tests. So yes.
So just saying that we do a ISC and TTF1 positive and we say it's a lung adenocarcinoma with VAF of 1%.
So
what to do?
What does it mean? What does it mean? Yes, to the molecular pathologist. What does 5% mean? What does 20% mean?
Yeah, but we need to look whether it's a canonical or a non-canonical mutation. So like for EGFR with 80% tumor content and if 1%
So I also
is
think
present,
like him. So if only
then I think we
1%
should
tumors have
consider
this,
that.
only 1% will respond to the TKI. What about the other 99%? Right. Right. Sure.
Just to add, the VAF, either a variant allele frequency or a minor allele frequency is a bioinformatics estimate. So with regard to you need to corroborate that with either there is a tumor mutational burden for that and all. So that way, 1% here when the Professor Amit said is in the way saying that whether the efficacy in the future, if we based on this particular deletion, we make a decision to go ahead with the treatment. So the treatment efficacy is what makes the difference for means lower confidence interval for the 1%. Yeah.
Sure. And to add to that, I mean, this is just an example of the kind of exon 20 mutations, deletions. We had an excellent talk by Dr. Anu, she's not around. And she showed us that, I mean, it's not only about the mutation, but it's also just recently we saw like with this drug poziotinib, whether it's a closed loop, far loop, and so it's like, it's even if you have an exon 20 insertion, me and Bhavesh will jump up with joy and say, we have got a mutation. And then they'll say, no, this is actually a far loop mutation. And the forest and the waterfall plot doesn't look that great. So how is it possible in today's day and age to kind of have that level of interaction between the lab and the clinician?
Definitely, I mean, this is a challenge. I mean, this is a challenge, and that's why you specifically and particularly require a multidisciplinary tumor boards where people from different expertise, from different background, they come together, they understand, and they deliberate upon the question. I mean, it is seemingly not possible at all or not feasible at all, and unfair to expect that medical oncologist would know nitty-gritties and the details of it.
So
That is
Bhavesh,
absolutely not something
Bhavesh,
that
if you
should
have
be
a
expected.
patient with exon 20 far loop mutation, would you use poziotinib in which line of treatment?
Maybe I think after
And
I
you have this
exhaust-
information on day one. I mean, so would you?
So I know that the water plot is not very impressive. So probably I'll go with chemotherapy, which I know that it is going to act. And I may keep it, chemotherapy, what I meant. And later, maybe if I have exhausted the lines of chemotherapy.
So
and
which
it's not
line? As
working,
Kumar sir was saying, there is 6 lines,
Beyond-
7th line.
So beyond at least 2 lines, because I think most of the patients are able to go at least up to the 2nd line, at least half of them. And beyond that, if patient is still surviving and has the disease,
So Dr. Amit, you
maybe I
have a
will
lot of
try that.
experience with serial checking, monitoring, biopsies. So would you act on these mutations in the 3rd line, 4th line, or you would insist on a repeat biopsy? If we have like a far loop exon 20 VAF of 10%,
So
a
we know that
baseline.
poziotinib is not a good drug to choose. So in that case, and poziotinib is also not available in India, if I'm not wrong, because I have never tried. It's not that easy a drug to tolerate. So poziotinib is not my choice. But in this case, we could have given osimertinib. There is one which is easily doable. But again, so your question was that will
My
you
question
repeat
was
the
like,
biopsy? Repeat
yeah,
the biopsy?
would you act on an NGS which was done on a biopsy many months or years ago, and patient has had 2 or 3 lines of treatment after that?
Okay, so this is a very good question. So if the patient had a driver mutation and you have not used target therapy, the driver mutation will be the same one. Then in my experience, and also the literature says that there won't be any clonal subclones which are going to develop which will be resistant, because it's just the chemotherapy what you have used. Had it been if you have used the target therapy, then you should do a repeat biopsy to see what new clones have developed and which you have to address now.
Sure. So that repeat
yeah.
biopsy, I mean, there's so much to discuss. We don't have
I'd
time.
like to add something that also depends on how the patient is progressing. If I have a report of the previous year and the patient is really bad, the clinical scenario has changed, then I would want a new one.
Yes. So Bhavesh, we'll just touch upon that. So this is a patient who, the first picture I showed you, had an exon 19 deletion, received osimertinib, and right now you see this current PET, everything is responded, and she's got a solitary progression of the lesion in the right upper lobe. So in this situation, your options are repeat tissue biopsy, repeat liquid biopsy, or no biopsy, and just go ahead and add chemotherapy or radiation therapy.
So if it is in what I would consider this as an oligo progression, because PET scan does not show anything else, I would try to continue osimertinib and try to give local treatment there.
Yes, so that's what most of us clinicians would do, and that's what was done for this patient. And this, yes.
Just back to differ because 17 months of disease-free interval, what you have got with osimertinib, it's a time that the patient will develop the secondary mutations.
Correct.
So you
So,
have
that
to
is
investigate.
what I was trying to bring
Yeah,
up.
yeah.
There will be half clinicians would do a biopsy and will
Yeah.
have a report full of mutations, and that's what I was trying to highlight in this slide. And then there will be another half of clinicians which they will say, I will use my surgeons, my radiation colleagues, and I don't care what resistant mechanism is. And we will just think about it when time comes, right? So we really don't know which is the correct approach. And patients also come in here. Some patients will say, I don't want to do a biopsy.
So regarding the osimertinib case, it's a good question because you are going to give osimertinib beyond progression. It's a cost involved. It's better whether it is going to work or not. You should be double sure.
Correct.
That is the advantage. That is why you want to know more about it.
Correct. So this patient anyway was not my patient, so anyway, was treated with radiation, and then later on you see there's a disease in the abdomen. Bhavesh, here you will want to do a biopsy, yes, correct?
Maybe it is out of the
Yes,
lung.
so now I'm not listening to you, I listened to Dr. Amit, and we have done a biopsy. Okay, so we've done a biopsy, and then biopsy shows it makes small cell histological components. So now this again brings us to the importance of rather than having a tissue before you look at the NGS. If we had not done this biopsy, would you have would any of the tests would have predicted a small cell transformation?
I think.
So what is that little bit?
RV, yeah.
Right. So you're saying those mutations would not be present baseline; they would evolve.
Yeah.
P53.
Are they the acquired risk? So we can
Okay,
go for the
actually,
repeat biopsy.
Can I add?
Yes, ma'am. Yes.
We're usually doing NGS in most of the cases. We have a custom-made panel, and the patients who are having TP53 and RB1 mutation, especially at the beginning, and initially maybe they were adenocarcinoma. You later on see the second biopsy, the small cell transformation has occurred. So there may be sense of doing an initial biopsy. You will know which patients are likely to be more aggressive or progress into something else. And small cell change cannot be picked up by any NGS. You will need a histological diagnosis for that.
Correct. And we know that a fraction of patients have small cell transformation because because this is a relatively common disease. We have these serial biopsy studies, and we are aware. What about rarer cancers? We don't have such information, right? I'm sure there are a lot of other rare cancers which are transforming, and we don't know because we don't have such kind of series. So that again just highlighting to kind of try get a tissue as much as possible, even though I think I'll see everybody's moving towards liquid biopsies and with the cost coming down. So Dr. Bhavesh, now there is small cell. What if this also had that C797S, what is responsible to, which may respond to erlotinib, right? That's one of the common mutations. So sometimes you have these various things, and how do you choose now? And we don't have head-on trials.
So I think I would go by both the information what I have. If the patient is fit, probably I would try to combine. But if patient is not fit, probably go by only the targeted agent.
Sure.
Yeah. Can I add something? I want to add something. You said that the patient has C797S mutation. So there is another very important point which has to be noted if you're planning to add erlotinib, that the mutation is cis or trans to T790M. So, okay, if it is on the same allele, then it may not make sense. But if it is trans, then it makes sense to have osimertinib and erlotinib together. So that information is very important, which has to be provided in the report. If somebody is reporting C797S.
Now coming to the kind of situation Dr. Amit usually has, and you have to combine. So now suppose the patient is well read and says, Doctor, I have read immunotherapy improves overall survival in small cell cancer. I want to take immunotherapy. What do you do with the TKI part of the treatment? Okay, so you will say no. Okay, you will say immunotherapy, but you will stop all the TKI. You will stop all the TKI. Bhavesh, agree?
I may not do that in clinic.
No, and then we read about case reports of ILDs in patients who are again given TKIs after immunotherapy. So all sorts of things. So I would say that I don't think anybody can make the best decision. We all will go wrong many times.
Stopping a TKI always has to be based on a molecular evidence. And as what Moshmes just said, if you have that information that whether these two mutations, the C792S is cis or trans, along with the your exon, along with the T790M mutations, or so unless if you have that information, definitely leave aside the TKI and then moving on. But if that information is that it is trans and there are different clone of cells having different mutations, then continuing with the TKI or setting it aside would not be a very prudent decision without having this information. So that's what I would.
So if you have this heterogeneous disease, when you have adenocarcinoma and small cell transformation, it is not 100% transformation among the two histologies, which is the aggressive one, small cell. So treat the patient with small cell dominantly, and then you take it off after, maybe after 3 months, evaluate. If the small cell component is gone, you go back to your TKI.
Sure. So
Why not?
sometimes I think so there's a clash between what the clinician feels, his gut feeling and his experience, versus what the ClinVar or the recommendation is for that particular mutation.
Can I?
Yes.
Can I add one thing? Yeah, can Dr. Ashish, I want to add one thing. So look, when we biopsy, we just have to be lucky to find the small cell component. Okay, it's just a biopsy. You may actually be a combined tumor with small cell and adenocarcinoma, but you just picked up adenocarcinoma, or like you picked up small cell, and then you on molecular profiling you have a del19 or L858R mutation. So that is a possibility. You just have to be lucky. So how will you treat that patient? So how do you know? We just go by the molecular this thing, and if clinically also the patient is not fitting into that.
Yeah, and a lot of the time, actually, suppose this patient progress only in the brain and we don't have a tissue. And in that situation, I mean, how we hardly do brain biopsies unless there's one lesion or 2-3 lesions. So that's always a challenge. And then what Dr. Amit says that if we don't pick it up on a biopsy, none of us know about it. Nobody will ever think of etoposide and immunotherapy in this disease. Yes.
As Dr. Amit was saying, he asked the pathologist what percentage they what percentage is small cell. Sometimes we get a small tissue. We cannot definitely say the other tumor will be heterogeneous.
And if you bug your pathologist too much, then he will not even take your call after that. Yes, so you're talking about tumor heterogeneity, and we always know that that's always going to be the case between the primary, between the metastasis, within the same tumor over a period of time. So I would say, I think ultimately is the patient's luck that the doctor knows what he has.
So with the scenario of small cell transformation, so whatever we have seen in our molecular tumor board is that no matter what is the component of adeno or what is the VAF of any of this EGFR, I mean mutations, if it is a small cell transformation, they treat it with small cell without adding any EGFR TKI. And for that matter, even in treatment naive, if it is to start with mixed adeno with small cell, still the treatment is directed to small cell.
Again, so because we know that's an aggressive disease going to kill your patient within a year, we want that control first before we think anything else. Okay, so I think we are way past our time. I had 3-4 more cases, but maybe in next meeting we will discuss that.
So this might not be totally accurate, but today that I have a patient who has adeno in a biopsy, but when we did adeno in the fluid region, it was sent for molecular, sent for molecule, but the biopsy from the lung is small cell. And the TDF1 may be positive in small cell, also in fusion. So how to differentiate whether that TDF1 is due to small cell or due to adeno?
So all small cell of lung have TTF1 positivity, most of it. So when you see like crushed cells, lot of crushing, you have to put a neuroendocrine marker, which is very difficult in pleural effusion sometimes, but you still see very high NC ratio and lot of poor preservation. So that time with TTF1, please do add neuroendocrine markers, and then only you will be able to pick it up.
Was positive moderately, cytoplasmic pomegranate but we did a lung biopsy, it is clearly adenocarcinoma.
Clear? You mean there is no small cell component?
In lung, there is no small cell. Fluid effusion is, they said BK1 point is CD50
No. So when you have a query, CD56 can also come in carcinomas. It is not a alone standalone marker for neuroendocrine. So what we do is we put a cytokeratin and we put neuroendocrine. So in small cell, the cytokeratin have a typical dot membranous which we see in carcinoma. So that is a very good point to differentiate. No. So you. No. When you cannot call it small. Yes, yes.
Sure. So thank you, everyone. We have another workshop the same, so we can't encroach upon their time. So we will definitely continue this.
Thank you so much. I hope you all have enjoyed this academic feast, and sorry for the late lunch for you all. Thank you so much.